Foxy. I don't know, Dr. Jaideep Tank may not be here, but he's always a driving force and who has given us a free hand and always been encouraging and inspiring to do all our work in Foxy this year. So thank you, Dr. Jaideep Tank, sir. When we can we have the next slide, please? Shreya? Yeah. So he needs no introduction, of course, but whenever he comes, he will join. So he is the current president of Foxy and has been the Secretary General and has been instrumental, as we all know, in formulating different guidelines and also has been drafting the proposal for FICO, which has resulted in a huge grant of $13 million for a 10-country project. And he's the technical lead for the project, and he's currently working on developing a proposal for a 6-country project on menstrual hygiene. Sorry, can we please mute everybody else who's not speaking? Thank you. Oh, thank you, sir. Sunawala sir has joined. Welcome, sir. Thank you, sir, for joining.
Thank you. Thank you.
Thank you, sir. It's our pleasure and honor indeed to have you in this program. Thank you, sir. So next, can we have the slide of Dr. Madhuri Patel, madam? The first Secretary General of our Foxy, Dr. Madhuri Patel, who's ever been so approachable and so helpful and friendly in all our activities. She always makes it a point to come to all our webinars. I'm sure she's busy somewhere, but she has said she'll join as soon as she gets the time. And she's also the editor-in-chief of Jogi and Joint Secretary of Foxy in 2009 and has a lot of credential awards to her credit. And may I now have the honor to invite and introduce Dr. Parul Kotadwala, a chairperson for ICOG, who's again, thank you once again for giving this opportunity. He's an endoscopic surgeon and consultant gynecologist at the VS Hospital and NHL Municipal Medical College, Ahmedabad. He's also been the vice chairperson of ICOG, chairman of ICOG in 2020, vice president of ISOPUB in 2020, vice president of Foxy in 2006, president SOGOG in 2009, president AOGS in 2007-2008. He's the Indian coordinator for the NESA New European Surgical Academy and also the coordinator for International Adhesion Society. Thank you so much, sir. And please, may we have your words of pearls of wisdom and your blessings for this masterclass. Thank you.
Thank you, Dr. Sita. The wisdom and blessings we should get from Professor Sunawala, sir.
Yes, I will ask him to speak as soon as
Thank you for taking up this very important topic. And I see that 73 people are already there online. So that shows that how much is the curiosity for our members to the issues of genetics. It is always such a confusing area for me because many things people mention about reporting, but what should we do remains a dilemma. So maybe this particular program will throw more lights on clarity, because most of the time, whenever I have subjected a patient to genetic testing, barring it is normal, whatever they write is such a confusing long language. And then what would be the outcome or management plan remains a curiosity. So thank you very much for taking this up. I see so many of our senior colleagues. Dr. Jaideep Malhotra is there as a guest of honor. I do not see Dr. Kailash. Is he online?
He will join. He'll be joining from the UK.
He has a talk also, no?
Yeah, he has a talk later on. Yeah.
I see our past chairman, Dr. Mala, also here. Very active Foxy member, Chinmayi also there. I welcome you all and let us get on with the program. Sunawala sir has always joined our ICOG programs during this year. I do not know about the previous years, but thank you, sir, for being there.
No, it's always a pleasure.
Yes,
Especially very, very essential part of medical care nowadays.
Yes. And now the patient awareness is always there. So patients keep asking us that, sir, do we need this testing also? They volunteer for that. Okay, let us get on with it. Please continue. Thank you.
Thank you so much. I have the pleasure to invite and introduce Dr. Sheila Mani, the ICOG West chairperson. Don't think she's here. She's currently abroad, having received the honorary fellowship causa of the RCOG. So hearty congratulations, madam. And it's my honor to introduce our secretary, ICOG, Dr. Sarita Bhalerao. I don't know if she's joined. Can we have the next slide, please? Yeah. So Sarita Bhalerao, who is the Secretary ICOG now and has been the chair of the West Zone India Representative Committee RCOG, also has been the President MOGS 2021-22, Joint Secretary of FOXY in 2017, past chapter of the Secretary of the Indian Menopause Society, and again, a very good friend who's always given us a free hand to arrange all these programs, has been very helpful in organizing this one as well. Before I invite our guest of honor, Madam Jaideep Malhotra, Madam, may I please ask Sunawala sir to say a few words with your permission, Madam. Dr. Sunawala sir, if you can give bless us and give us a few words of wisdom for this masterclass. Sir, you there? Sunawala sir, can you hear us?
He needs to unmute himself.
Yeah, sir, can unmute yourself?
Oh God.
It's gone. Okay, when he comes back then. Can we have the next slide? Yeah, it's my indeed honor and privilege to introduce our guest of honor, the very talented, the very enigmatic, the inspiring, the role model for a lot of us, Dr. Jaideep Malhotra, madam, who needs no introduction at all. She's been our past president of FOXY, past president of the Indian Society of Prenatal Diagnosis and Therapy, past vice chairperson of the ICOG, President of the Dubrovnik International University, Croatia, Regional Director of South Asia Indian Donnell School of USG, member of FIGO Committee of Reproductive Endocrinology, and recipient of the Honorary FRCOG FRCPI, recipient of Nepal Samman, Lifetime Achievement Award of ISSRF, DLA Women of the Year Award, Amar Ujala Gaurav Samman Award, India Book of Records and World Records of India Awards, Economic Times Most Inspiring Women Award, Swayam Siddha Award by the Honorary Governor of UP, Shri Ram Nayak Ji, Indumati Zaveri Prize Award, Dr. M.T. Hansotia Award, Best Committee, Jagdishwari Mishra Award 3 times, Kurion Award, Forbes for the Most Successful Woman, and many more awards, and this to her credit. So it's really been an honor for you to join us as the guest of honor, madam. Please give us your words of wisdom and your blessings as well. Thank you so much.
Thank you, Sita. Thank you so much. And a very, very good evening to all of you. It's such a pleasure, to be addressing this August gathering. And Sir Sunawala, sir, my pranam to you. It's always a pleasure to see you and, get all the positive, good vibes from you. It's not today, it's been for the last 4 decades. And it's a real privilege to have you here amongst this masterclass. Sita, Parul and Sarita, a wonderful, wonderful choice for a masterclass because, we have already known that there are a lot of gray areas in our practice. And it is something which, it eludes all of us as far as genetics is concerned. And there are so many, wide disparities in our practice, and these disparities in our diagnosis, and then the outcomes are also very, very different. A lot of times we question whether there is a real utility of whatever we are doing. What is the cost benefit analysis of the various tests which we may do or which we may not really do, and also of the various procedures. And it's not only for us, the dilemmas are also there with the patients. And I feel really happy and excited when I see the program today. I mean, I'm currently looking at a lot of these genetic issues which are there. And a lot of times I myself used to feel very inadequate in addressing a lot of issues which we face in our day-to-day practice. So when I looked at the program, you have picked up very, very important and very key daily problem subjects. And the faculty is even more exciting because I've known each and every one of them. And it's really, they're masters in their own field. This program is going to be very, very exciting. I sincerely congratulate you and the whole team and the faculty. And I'm sure people who are going to attend today's program are going to be immensely benefited. And I always feel that, one thing that we must practice whatever we learn as soon as possible before we forget it. And knowing is also not enough. We must apply it. And willing is also not enough. We must do it. And let's keep on doing all the good work which we can and creating a lot of awareness. And yes, of course, all these things need to be taken with a pinch of salt because evidence keeps on changing. So once, today whatever we are thinking is beneficial may not be as beneficial, it may not turn out to be as beneficial in the times to come or vice versa. So let's keep a very open mind and, broad outlook and then apply ourselves to the best of our abilities for the best of outcomes. So all the best. God bless you all for a very, very happy learning.
Thank you. Thank you, madam, for your kind words and blessing us. Really looking forward to an exciting program. Before we start, I would like to welcome our other chairpersons who have agreed to be there, Dr. Mala Arora, madam, Dr. Rakhi Singh, and we start the program. And Sir Sunawala, sir, can you please give us your words of wisdom before we start the scientific sessions? Thank you.
No, from right in the beginning of my practice, I had realized that genetics is the medicine of the future. And we started the Indian Society for Prenatal Diagnosis and Therapy in the 80s. And more and more information came in, especially when ultrasound developed and the chemical tests and gene determination and all that new technologies came in. Genetics is now in the forefront, whether it's malignancy, whether it's infertility, whether it's any problem, somehow it is connected with genetics. So to be an expert in genetics is very difficult. So let there be some people who are very keen to develop their skills in genetics. And there is no harm in referring your patients for an opinion to an expert who will be able to guide you. Then NIPT and all the present things that have developed, the main purpose is to avoid congenital malformations in the newborn. And I'm so glad that the Obs and Gynae Society, FOXY, and all are now taking so much interest in development of genetics. I wish this conference or get together maximum success, and more participants should join in to be able to learn more about genetics. Thank you very much.
Thank you so much, sir. It is always inspiring and to see your enthusiasm even now to learn. And I think we should be, that's the guiding force for us. And we have all the experts here. Dr. Sari, thank you once again for your words of wisdom and your blessings. Thank you so much. Dr. Sarita Bhalerao has joined, so may I please invite her to give a few words of introduction, and we can go on with the scientific sessions. Sarita, you there?
Thank you. Yes, thank you, Sita. I'm very much here. And very good evening to everyone here. Dr. Sunawala, sir, thank you so much for joining. Really a pleasure to see you. I must take this opportunity also to thank our chief guest, Dr. Jaideep Malhotra, and also to thank Dr. Sita for taking these efforts to do all this. And a great happy learning this evening, and we can go ahead with the program.
Thank you. Thank you so much, Dr. Sarita. Dr. Shruti, I think we'll move on to our scientific sessions. We have all the chairpersons here. So thank you once again, Dr. Kushagrati Ghosh, Dr. Mala Arora, Dr. Rakhi Singh, and the speakers as well who will be joining. I will give the official vote of thanks. So over to you, Shruti, for the first session. Thank you.
Thank you, ma'am. So starting with the first session for the day, genetics and subfertility. I would like to invite chairpersons for the session. Shreya, can you please put the previous slide? I would like to invite Dr. Rakhi Singh. Madam is president of Noida Society.
First one is Dr. Mala.
Mala Rora is first.
Yeah.
Okay, so welcome, Mala ma'am. Ma'am has been chairperson ICOG 2017, vice president Foxy 2011. She's also the editor of Recurrent Pregnancy Loss Edition, and she's the founder of Indian RPL Foundation. She's also the vice chairperson INT SOC RPL, and she's the chief editor for Recurrent Pregnancy Loss and World Clinics in Obs and Gynae. She's also received DC Datta Award for Yearbook of Obs and Gynae. She's chief editor for Evidence-Based Medicine, Endometriosis and Homocystinemia. She's also the associate editor and peer reviewer for many national and international journals. Welcome, ma'am. Now, I would like to welcome Dr. Rakhi Singh. Ma'am is president of Noida Society. She's also the governing council member of ICOG 2024-25. She's vice chairperson of UP State ISAR and peer reviewer for Journal of Obstetrics and Gynecology and chairperson of Endocrinology Committee Foxy. She's been invited faculty for many national and international conferences and has been convener for Foxy, ICOG, GCPR. She's editor of Foxy Focus. She's received Foxy DC Datta Award and CS Dawn First Prize at AICOG 2023. She's written many chapters in various books and has received Wonder Foxian, DIRA Award and ICOG Appreciation Award. Welcome, ma'am.
2 minutes.
Thank you. Thank you, Dr. Sita, for inviting us as chairpersons to this very informative webinar on genetics. Can I have the...
So sorry to interrupt.
Dr. Rakhi Singh is the co-host now.
Yeah, so Dr. Veronica has an issue, so she'll be talking later. So this session we'll be having Dr. Seema Thakur, madam, and Dr. Shagun Agarwal as the two talks. So Dr. Veronica
I'll
will be
introduce
talking
Dr.
after Seema.
Seema.
Yeah, okay, thank
Yes.
you.
Can I have her CV on, please? So I have known Dr. Seema Thakur at a personal level for many years in Delhi. She has been a chief geneticist at Gangaram Hospital and then Fortis LAFM. And every time I have referred a patient to her, she has been very, very not only up to the mark with her genetic diagnosis, but also very helpful in genetic counseling, trying to sort out cases and arrive at a diagnosis. So thank you, Seema, for all the time that you have helped us. I can now formally say that she's associated with Fortis Shalimar Bagh as well as Rainbow Children's Hospital, Delhi, and she has a genetic clinic in Dwarka. Her area of interest is prenatal diagnosis and genetic counseling and fetal syndromic diagnosis, interpretation of genomic data and clinical correlation. And she's now interested in artificial intelligence that is going to invade all our lives to help us solve many puzzles that we cannot put together on our own. She is the recipient of title of professor by Apollo Hospital Education and Research Society and a Distinguished Medical Luminary Award by IMA and Women's Doctor Association. Over to you, Dr. Seema, for your presentation.
Thank you, ma'am, for such a introduction. I would like to share my screen, Dr. Sita.
Shreya, just mute her.
Shreya, can you mute everyone, please? Not Seema Thakur, madam.
While Seema is getting ready, I can just introduce to the audience that it's easy to order a test as we have all felt, but it is so difficult to interpret and counsel your patients. Specialist in your team to be able to help you do that, because there's still a lot of lacunae in our understanding, and hope Sita, with this webinar, we will all be educated.
Then you're unmuted.
Okay,
Please unmute
yes.
yourself.
So
Yeah,
my screen is visible.
yeah, it's visible.
Yeah, so first of all, ma'am, thank you for such a kind introduction. I really feel overwhelmed over this introduction. And thank you, organizers, for giving me this opportunity to talk about the recurrent pregnancy loss, which is affecting silently many women who are unable to, discuss their problems. And at the same time, we find ourselves a little, not very much, but to solve their problems. So I'll be discussing about the definitions, the etiology, the genetics, and one algorithm at the end for the cytogenetic or non-cytogenetic testing in the RPL. So as we all know, there are two types of miscarriages, the sporadic and the recurrent. The sporadic miscarriage is often the result of the random fetal chromosomal abnormality. So it is generally attributed to the fetal problems. And the recurrent miscarriages has traditionally been defined as the 3 or more miscarriages and affects about 1% of the women. Incidence increases with the maternal age. So it is 10% when they are 25 years of incidence will be about 50%. So increases with the maternal age. Till now, the most known etiological factor or the predisposing factor was the number of previous miscarriages. That the more the number of previous miscarriages, the chances increases. But recently, the guidelines suggest that advancing maternal age, advancing paternal age, they all have a equal contribution to the subsequent miscarriages. The spontaneous abortion, any first trimester or the pregnancy loss before 20 weeks, intrauterine fetal death or the stillbirth, are the chromosomal, and 10 to 15% of the all pregnancies end in the abortion. So genetics play a big role in the management of. So the key message is the less than 20 weeks is the abortion and more than 50 weeks is the stillbirth. So the recurrent abortions, there are various definitions. As per the recent classification by the ICOG, they still say that the 3 or more consecutive first trimester abortions are considered as the recurrent abortions, but the ISHRE 2022, they consider 2 or more clinically recognized, confirmed by HSG ultrasound or the histopathology. So in our practice, we are using 2 or more recurrent abortions as a definition of the RPL. And the incidence is 1 to 2% when we take 3, and it increases to about 5% when we include 2 or more clinically recognized pregnancies. So whenever we see in our clinic that the lady is having 2 or more, this is an important slide that we tell them at the first visit that the etiological diagnosis is important to reach the management, and the cause can be in 50% cases only. So there is limitation to all the workup. But at the same time, we pass on a very good positive note. There are 60 to 70% chances of live birth even after 2 to 3 abortions. So there is a Lancet 2021 which says that out of the 9 studies, the women with no history of miscarriages, the risk is about 11%, and the risk increases to about 10% for each additional miscarriage. So we can remember like that, if there is no loss, the risk is 10%, 1 loss, 20%. So it's easy to remember the figure of 10, 2 loss, 30%, 3 loss, 40%. So we have to tell them that even after 3 losses, there are 60 to 70% chances that there will be a normal good outcome after 3 losses. So the causes of the recurrent miscarriages, so this would include the anatomical, that is beginning from the uterus. So there will be some anatomical abnormality in the uterus, then the uteroplacental surfaces. It could be like antiphospholipid antibody syndrome, then the endocrine milieu like thyroid, diabetes, they can also contribute to the recurrent miscarriages, and the genetic, which accounts for about 5% of the cases. And despite all investigation, there is 30 to 50% limitation. So we have to know that the recurrent pregnancy loss is not a genetic illness, it is multifactorial, starting from the anatomy. The most would account for about 7%. They could be or congenital. The congenital one include septate, unicornuate, the bicornuates. They are present in about 13% of the women with the RL, and in the normal women, it is about 5%. So roughly about 3 higher in the women loss. So these are the different, the unique uterus, subseptate uterus, the acquired abnormalities like submucous myomas, which are generally predisposing to the recurrent abortions, or the intrauterine adhesions. Then the most rewarding to treat is the antiphospholipid antibody syndrome, which are actually predisposing to the thrombosis at the uteroplacental surface. So this is the most important treatable cause of the abortion, and this accounts for about 50% of the cases. And we have both the clinical and the laboratory criteria. And here we can see that even if one of death of the normal fetus at more than 10 weeks is included in the clinical criteria, and this in contrast to the more than 3 which we normally include, and it has to be supported by the laboratory criteria of the anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein IgG and IgM. So we have to notice that only these 3 are included in the laboratory criteria, not the antiphospholipid as a whole. So we can order only these 3 to support the diagnosis of the antiphospholipid antibody syndrome. So this is one case where there was a 3 recurrent first trimester abortions. She consulted at 5 weeks to us when no fetus was visible on the ultrasound, and we advised them to antiphospholipid antibody panel, and the ANA was positive, and if dsDNA was positive, and the lupus anticoagulant was positive. So she was started on the heparin, aspirin, and because of the ANA positive, she was also started at the HCQS. Cholesterol developed at around 28 weeks. She delivered at 38 weeks. Next pregnancy also, we did this. She had a normal pregnancy outcome. So when we treated, this was rewarding to us. And the endocrine factors could be thyroid, diabetes, polycystic ovary disease, luteal phase deficiency, hyperprolactinemia. So we need to investigate for the diabetes, PCOD. So coming to the sporadic abortions, they could be 50% of them are due to the chromosomal abnormality, and they could be trisomy 22. So about 50% would be normal. So the chromosomal abnormality which come for the recurrent abortions, they could be involving the autosomes or the sex chromosomal abnormality. They could be the numerical abnormality where there is 45X or 47XXX or 47XXY, or it could be a structural abnormality in the form of the balanced translocation carrier, where there is between the 2 chromosomes, there is an exchange of the genetic material resulting in the balanced translocation carrier, where there is no net gain or loss of the genetic material. This is a lady who had a balanced translocation carrier. You can see here she had 5 losses. Some of them were biochemical, some of them had cardiac activity present, and all her workup was normal except the karyotype, which suggested that she is a balanced translocation between chromosome 1 and chromosome 3, we can see here. And so how to counsel a couple with a balanced translocation carrier? We have to tell them that the incidence is common, 1 in 500 in general population, and this is common about 5% in the children, in the patients with the recurrent pregnancy loss. And carriers of balanced translocation, they are themselves healthy because there is no gain or loss of genetic material, but they are liable to produce the unbalanced gamete during the gametogenesis. And how much risk we assign to them? We say that the risk is about 30 to 50% of the risk of abortion, or the risk of a child with the mental subabnormality, or the child with malformations. So what are the options available to these women? If there is a good fertility, like she is conceiving fast, like in the previous case, we offer them a good anti-scan followed by an amniocentesis at 16 weeks. But suppose if she has an added element of the subfertility, then these are the women whom we ask them to go with the IVF followed by the PGTSR for the balanced structural chromosomal rearrangement. This is a male with a balanced translocation carrier, and he had a karyotype of translocation 7 to 21. So here because they had got about 7 abortions, Probably this could be due to the interchromosomal defect, and probably they would require cases with PGTSR or the donor. Then the people with the reproductive, with the sex chromosomal abnormality, this is the case. These are the cases with the triple X. Most of them presented to us with recurrent, but in the next pregnancy, they had the normal baby. So what is the recurrence risk which we assign to these women for their ongoing pregnancy? That the risk of the recurrence for their next child to have this trisomy X is less than 1%. And majority of these women have normal puberty and fertility, and they have a very small risk for the sex chromosome in the next child when they would conceive. All this because NIPT for sex chromosome is revealing many of the women as the triple X, and many of them are being terminated just because they are triple X. But as an obstetrician, we need to know that most of these women will go undetected throughout life. So the triple X on the amniocentesis is not an indication of abortion. They will have normal IQ, normal puberty and fertility, and even the recurrence risk for their children will also be less than 1% only. So based upon this information, they should not be advised the termination. This is the case Turner syndrome. Of course, she underwent IVF because there were recurrent abortions, and she already had undergone the PGTA, but she was advised NIPT, which suggested that there is a Turner syndrome. We performed amniocentesis that showed normal results, but at the same time, the mother sample, which is being sent for the qPCR, that suggested that the mother is a mosaic for Turner syndrome, and that was the reason for the false positive NIPT for the Turner syndrome. This is a male with ring chromosome and Turner mosaic. Very surprising, he is a male and still having the 45X. And out of the 50 cells examined, about 29 were ring chromosome of Y and 21 were 45. But he was absolutely phenotypically a normal male, except that he had a low sperm counts like 4.5 million, mortality 20%. And so we searched the literature and we were amazed to see a male with the Turner. So we found out that from the literature that this type of karyotype has a variable phenotype from normal male to ambiguous to the Turner syndrome, and two options, reproductive options we gave to them, that IVF with PGTA and transfer of the XX or IVF with donor. The family decided to go ahead with the donor because they were not ready to afford another loss. So what do we tell? The literature suggests for the PGTSR in the balanced translocation carrier, they suggest that the live birth rates are similar whether we offer them the PGTSR or whether they go ahead with the normal pregnancy. So there is no added benefit, and also the time to pregnancy was similar in both the groups, but there is a reduction in miscarriage rate, but at the huge cost. So we should routinely not be asking any pregnant women with the balanced translocation that IVF and PGTSR is the treatment of choice. Rather, if there is a good fertility, they should try their natural conception, unless they don't want to have much sorrow, then probably they can offer. Otherwise, routinely they should not be offered. Then routine PGTA for idiopathic PGT, the latest literature in the RCOG that shows that the live birth rates are similar whether we offer the PGTA or without any add-on test of the PGTA. So then coming to the test on the product of conception, the CMA is the test of the choice in the current time, maybe in the future, the exome sequencing may be. So the guidelines do suggest that the CMA is the first year test in any antenatal testing, including the product of conception, because excluding the maternal cell contamination is of utmost importance in the cases of the products of conception, because many a times this will be falsely normal because of the maternal cell contamination and results. And also not only the accuracy of the result increases, also because this is a CMA with higher resolution than the karyotype. So there is additional diagnostic yield of about 2 to 3% beyond the routine karyotype. So this is the first test of choice in cases of any product of conception testing. So the CMA can identify the maternal cell contamination. If there is a maternal cell contamination, we can refuse doing the genetic testing because this will be falsely normal. Then this can also identify that all these cannot be picked up by the karyotype. So there is a time we should, all the product of conception after 2 abortions, generally we ask them to go for the microarray, with maternal cell contamination. Then the single gene disorders, they could be inherited in autosomal dominant, autosomal recessive, and the inherited thrombophilia. So some of the single gene disorders which has been implicated in the recurrent abortion are the myotonic dystrophy, homozygous achondroplasia, Smith-Lemli-Opitz syndrome. If it is an autosomal recessive, the risk of recurrence would be about 25%. Some of the X-linked dominant, because this will be lethal to the males, could be incontinentia pigmentae, chondrodysplasia punctata. We had one case with the incontinentia pigmentae. She had a skin lesions detected at birth only, and she had another problem in the eye. So her mother came to us during the next pregnancy for the ongoing pregnancy, and we can see here there is a history of neonatal male deaths, and we performed the genetic testing and identified that this fetus is not affected by the incontinentia pigmentae, and the pregnancy was continued. So this is an X-linked dominant condition which will affect the male. Most of the majority of the studies would say that it is not useful to do the inherited thrombophilia study, but there is a great evidence in the, as mentioned in the current RCOG, that women with second trimester miscarriages, they may be offered testing for the factor V lead-in prothrombin gene, protein S, ideally within a research context. And based on this evidence, because of the factor V lead-in may be associated with the first and particularly the second trimester, prothrombin gene may be associated with the recurrent miscarriages, protein S, protein C, no association has been mentioned. MTHFR also no association. Conclusive association studies has been possible. So, it's a majority of them would not advocate, but it can be individualized based upon the case-to-case basis, and we can do the thrombophilia testing and do the heparin. So like this case, she is a para 0+3. All her investigations, karyotype, ultrasound, anticardial, they were normal. And we did the thrombophilia study, and the hereditary thrombophilia factor V lead-in was positive. She was a heterozygous. So heterozygous is the risk of thrombosis of 5 to 8-fold, but zygous, it will be very, very high. And association with particularly in the late pregnancy, but we managed this pregnancy, although this was the early first trimester losses, but we gave her heparin, and both two pregnancies ended well in a normal, healthy outcome. So in the current time when the NGS has been, touched the genetic testing all over, whole exome sequencing can be applied in the recurrent miscarriages again, and there are different approaches. We can use either the product of conception and the trio approach, or only the couple approach, or only the product of conception for whole exome sequencing. Even the whole genome sequencing has been starting utilized in the cases of the recurrent abortion, but generally these are all in the research settings only. So where I am using the whole exome sequencing in the cases of the recurrent abortion, this case will make us understand. This is so this case was referred to us for the post-test genetic counseling because she was having a mutation in the NLRP7, which causes recurrent molar pregnancy. So we searched the literature and found out that the women with NLRP7, they are themselves normal, although they have 2 mutations, but they are normal, but they have difficulty because of the conception, because of the establishing imprinting in the oocytes, leading to the recurrent mole or the recurrent pregnancy loss. So how do I identify these women? I order in each pregnancy, instead, I also offer the histopathology along with the microarray and try to identify the women who are having the recurrent molar, and then I would do this NLRP7. And if this is positive in the women, site is recommended in these cases, because all their pregnancy, because of the imprinting defect at the oocyte, they will be resulting in the abortions. So histopathology of the product of conception will guide us for the whole exome sequencing. And the most common question raised to us as a geneticist is how to. And this is how we say that if we are sending the blood, you send us EDTA blood, 3 ml EDTA or heparin for the karyotyping, but generally we are doing only molecular studies. So 3 ml EDTA, but blood is generally not available. So we ask the placental near the cord insertion, about 25 to 50% coincide is sufficient along with the maternal blood to do the microarray testing. So all placental sample along with the 3 ml EDTA blood of the sample is needed for the microarray analysis. Investigation for miscarriages, we have a first level investigation, and in the first level, the autoimmune like lupus erythematosus, the endocrine, parental karyotyping. We also do the POC on the product of conception, second or third abortion. Somebody even at the first, because trisomy 16 gives them a closure. But these investigations are not, and still the abortion is happening. Then at the second level, we do the ANA and all the hereditary thrombophilia. And we also investigate the male partner by the sperm DNA fragmentation index. If it is more than 15%, then that indicates that there are, chances of, because this may contribute to that. And despite all these, then at the third level, the clotting disorders may come into play, like factor 13, factor 8 deficiency. These are the coagulation disorder where instead of thrombosis, this is opposite to that. So this we try to investigate at the third level. And here we do involve our hematologist colleagues also to interpret all these coagulation results. So if a lady comes to us, for the cytogenetic testing during non-pregnant state, we're doing karyotyping. So in the pregnancy, we don't do in the non-pregnant state in the couple, we do karyotype. Microarray will not help in the non-pregnant state for the couple because the karyotyping is to detect the balanced translocation carrier. But during pregnancy, we would do the microarray. And all the women, whether genetic cause is identified in the POC or not, we do the workup of the RPL, the first level, the second level, which just discussed. So conclude, the couple with 2 or more pregnancy losses should be evaluated for the both cytogenetic and non-cytogenetic, because RPL is not entirely a genetic illness, it is a multifactorial, and CMA on the product of conception should be a first-year test for all POC, or at least from the second onwards. Unexplained RPL is only after the 10% will remain if we start using POC CR practice, and should be offered karyotype because exclude the balanced carrier. Microarray does pick up the balanced translocation carrier. No microarray testing in couple should be done. Cases of the balanced translocation birth rates are good with the expected management, though with PGTSR can be considered. X chromosomal abnormality, triple X, Turner mosaic, or even with males with this can have males with the Klinefelter syndrome. They all can have healthy offspring. It is high time that the triple X is in the synthesis is not an indication of caution, because majority of these women are going to do.
Hello.
Hello, I think we lost her. She lost her connection. Probably she'll join back. Just a couple of minutes to her.
Yeah, she's
No, I have done. Ma'am, I've already finished. So
Okay.
okay. Thank you, ma'am.
Genetic
Thank you,
testing,
ma'am.
that is the karyotype for the couple. So that was my last slide.
Okay.
Thank you, ma'am.
Mala, ma'am.
Mala madam is here.
She's there. She's there.
Yeah.
She needs to.
Yeah, thank you, Dr. Seema, for this. Can you hear me? There's still a lot
Yes,
of areas, like whether we should offer MTHFR screening in patients with RPL, and whether those that have an MTHFR positive gene mutation, homozygous, should have homocysteine levels checked to see if they are optimized or not. Plus, of course,
So,
lots and lots
we
of
should check the homocysteine level.
Yes. If they're, especially if they're homozygous,
is not, this is not
gene mutations. Yeah,
Even
heterozygous
we
is
check
not a risk
even in
factor for
heterozygous
RPL.
also. Yes, ma'am. Yes, very rightly said, ma'am.
Yeah.
So otherwise, and this is
Yeah.
not an indication of a CLEX. This is not election. This is just an indication. We should go do B12 pyridoxine supplementations. Because many times I find that MTHFR mutation is, they have been started the CLEX.
There are a few more questions. I think we'll take it at the end of this session as well.
Philic factor like APS positive with anticoagulation.
We can take it at the end. Definitely.
Right.
It was very comprehensive and complete genetic coverage overall. Dr. Seema ma'am. It was very good. Beautiful to hear too and understand all the genetics of it. Moving on ahead, let's have the CV of the next speaker, please. Next CV, please. Dr. Shagun. Let me invite Dr. Shagun Agarwal. She is the professor and head of the Department of Medical Genetics at Nizam's Institute of Medical Sciences, adjunct scientist center for the DNA fingerprinting and the diagnostics. And she's got many papers to her publications, 62 indexed and non-indexed also, an associate editor for the genetics update in the Next Generation Clinicians. She's got many professional achievements like ex-treasurer and executive committee member for the Indian Academy of Medical Genetics, secretary for the Telangana chapter, Society of the Fetal Medicine, DHR International Fellowship recipient in 2018, and holder for the 2 research grants, identification of the novel gene causative for the human phenotypes, and member for the International Fetal Sequencing Consortium and HPO Perinatal Groups, co-coordinator of SIAMG Clinical Genetics and Perinatal Genetics Fellowship, and research interest is genetic characterization of the fetal malformation syndromes. Welcome, Dr. Shagun, with a very decorated CV, and she would be speaking today on genes and male subfertility.
Good afternoon, everybody, and thank you, Dr. Akhi ma'am. So I'll just share my screen. If can unshare your screen, please? Yeah, thank you. I hope my slides are visible. Yes. Okay. So after this wonderful talk by Dr. Seema on the genetics of RPL, so we are going to focus on the genetics of male infertility. So of course, I need not tell to this audience. So male infertility broadly, if we have to classify it logically, this could be a quantitative impairment of spermatogenesis, which is the most common etiology of male factor infertility. Then we could have qualitative impairment, which nowadays we are seeing very often, and probably a lot of it is lifestyle related. And then of course there are some obstructive etiologies also which could be underlying. So but when we have to see a patient in the clinic, so this would usually be the kind of presentation which would be there, and that's from where I would take this talk, like for each of the different presentations, what could be the underlying etiologies and how do we investigate as far as the genetic aspect is concerned. So the most common, we could say, the abnormality where we are likely to find a genetic etiology is a male who has some kind of an abnormality in his semen. So this could be a quantitative abnormality in the form of an azoospermia or an oligospermia, or it could be a qualitative abnormality, which would be in either asthenozoospermia or teratozoospermia. And then again further, so the ones again which are more likely to be genetic are the ones which have a quantitative abnormalities. And these could further be hypogonadal, or they could be eugonadal men. So the hypogonadal ones, whereby these again further the problem could be at the level of the testes or the peripheral tissue hormonal action level, that is hypergonadotrophic, or it could be hypogonadotrophic problem at the level of the hypothalamus pituitary, which is much less common and easier to treat it by. And then, of course, there are the eugonadal men, which don't have any hormonal issues, but they are still azoospermic. And then the qualitative defects usually are less likely to be genetic, except for very few exceptions. So then we have some rarer cases where there are some syndromes, and there also the patient presents as with infertility as one of the component. And in such cases, you would invariably find other phenotypes or other abnormalities in the individual. And then there is, of course, a significant proportion of unexplained infertility, which does remain. So let's now quickly see the infertility where we have an element of hypogonadism. So this, I'm sure again, in the interest of time, I won't go too much in detail. So we could have problem at the level of the hypothalamus or pituitary, which is basically hypogonadotrophic hypogonadism, or a problem at the level of the testes, in either the gonad is failed or dysgenetic, or a problem in the production of the hormone, or a problem, hormone is there, but the action is not there. So problem at peripheral tissue. So this is hypergonadotropic hypogonadism. So now let's see a case scenario. So this is a 35-year-old male presenting with infertility, has some decreased libido, some other signs suggestive of hypogonadism, and it has azoospermia, high FSH. So once we see this, we know that this is a hypergonadotrophic type of hypogonadism with a low testosterone, high FSH levels. So here in such a case, the first test which would immediately we would be doing is a karyotype. So here this person did end up showing an abnormality in the karyotype. So we can see the 2X and 1Y. So this is basically Klinefelter syndrome. And this is a condition which is characterized by a testicular failure, and thereby patient presents with infertility, azoospermia. And these individuals are also prone to have multisystemic abnormalities involving especially the endocrine system and some predisposition to even developing varicose veins and other issues. So this is in fact the most common genetic cause of hypergonadotropic hypogonadism in males. Around 15% of azoospermic and 5% of oligozoospermic men will be having Klinefelter syndrome. And the problem here is basically a spermatogenetic arrest. So the management here in a significant proportion would involve use of a donor sperm for the purpose of reproduction. But then in around 40 to 50% patients, they do say that doing a testicular sperm aspiration and IVF is possible. In case this is done, there is reported to be an increased risk of aneuploidy in the gametes or in the subsequently the baby. So thereby, if you use the patient's sperms in case of Klinefelter for ART, a PGS has to be done to look for aneuploidy. And now, of course, we call it PGT now, PGTA. And then these, in addition to the fertility issues, of course, for the patient's health also, we need to provide enzyme replacement therapy and also monitoring for the systemic diseases. So this Klinefelter is a commonest etiology, but there are other uncommon etiologies of hypergonadotropic hypogonadism. So you could have a gonadal dysgenesis in various kind of karyotypic abnormality. Patient could be 46XX but having a SRY gene translocation onto one of the chromosomes. Patient could be mixed gonadal dysgenesis, whereby there is a cell line of monosomy X. And then patient could also be having normal karyotype, but various single gene defects causing a gonadal dysgenesis. And again in this category only, we have certain syndromes also. One of the commoner one which we do see very often in genetic clinics is the Noonan syndrome. So this is an individual who would typically present with a short stature, mild intellectual disability, or some borderline learning difficulties may be there. There could be other features like neck webbing, some facial dysmorphism. You can see the toes here. So this is sometimes also mislabeled as a male Turner. So because of the webbing, the short stature. And these patients, around 77% of them would have cryptorchidism, which could secondarily then lead to a gonadal failure and present as infertility. So here the important point is that this is an autosomal dominant condition in the majority. So in case there are sperms which are used for an IVF in such a patient, this disease can be transmitted and the offspring could have more severe intellectual disability. So it is important to recognize it in the clinic. So then you would have a patient who would be having the quantitative sperm defects along with some degree of genital ambiguity. So these are the patients who could have various combinations of these hormonal profile. And typically this kind of a clinical scenario is most commonly seen in the androgen insensitivity syndrome, the partial and the mild variety. And also quite common, equally common, I would say, in India is the 5-alpha reductase deficiency, which is an autosomal recessive condition. And rarer are these steroid biogenesis or LH receptor defects. So basically, these are the patients where the gonad is normal, but it's at the level of the hormonal production or the hormonal action that the problem lies. And that is what is causing the poor spermatogenesis and thereby the subfertility. So for the androgen receptor defect, which is an X-linked recessive condition, actually, we need to sequence the androgen receptor gene. And these patients, again, usually nowadays, we use NGS for this kind of sequencing. So then moving on to the hypogonadotropic hypogonadism, this is much rarer and it is easily treatable. So I would not focus too much on that. But the main important points here to remember, of course, all of you would be able to make a diagnosis here. They would have the low normal FSH-LH with the low testosterone. And then the problem can lie at the level of the hypothalamus or the pituitary. So the important thing here to remember is that most of these are autosomal dominant, and some of them can have additional abnormalities, so which may be variably expressed in the family. So what can happen is that the patient, the male patient in front of you, may be having a only hypogonadotrophic hypogonadism, no other manifestation, and when he transmits, because this is easily treatable, and when he transmits the mutation to his child can have these additional abnormalities. So that's why it is important to these patients also to undergo a genetic workup. A large proportion are because of genetic mutations in these different genes. And same holds true for the pituitary defects also, where we do see association with also something called as septo-optic dysplasia and intellectual disability, visual defects, which can be there for some of these patients. Again, a parent may not have it, the child may have it. So it's important to realize that these hypogonadotrophic, hypogonadic patients also should be undergoing genetic evaluation. And here, because there are multiple players involved, so typically here we use the test called as next generation sequencing based exome sequencing, where we can sequence all these different genes. So again, this point I've already said that there is a good prognosis for fertility. These are mostly dominant disorder with a 50% risk in offspring. So that to prevent the more severely affected offspring, we could offer them PGD or prenatal testing. So now let's move on to the eugonadal man. So a eugonadal man presenting with azoospermia, no other issues, again, could be obstructive, could be non-obstructive. If it obstructive, we know that a large majority are environmental, but in the genetic cause, we need to remember CABVD, that is a congenital absence of bilateral vas deferens, which is because of mutation in the CFTR gene. And the mutation in the same gene causes a much more severe disorder, which is called as cystic fibrosis. So again, these patients also need a genetic workup, because if they have this condition, if they have a CFTR mutation, their spouse or the wife needs to be tested, because their baby tomorrow may develop cystic fibrosis, which is a very severe disease of pediatric age onset. So here, basically, this comprises of only around 6% of the obstructive azoospermia. And to do the testing, again, most of the time we nowadays use next generation sequencing. We could also do targeted testing of the CFTR gene. So then moving on to the non-obstructive eugonadal azoospermia. So here the most common cause are the AZF deletions. So these are found in 20% of azoospermic and 5 to 15% of oligospermic men as a whole. So this AZF deletion is nothing, but there is a region on the Y chromosome where we have this AZFA, AZFB and AZFC segments of the chromosome, the Y chromosome, which are containing certain important genes for spermatogenesis. So deletions of these regions can present with, again, sperm abnormalities. And then there are various types of deletions, either involving all the regions or part of the regions. So usually AZFC deletion is the commonest, and this actually has a variable phenotype, and many of the males would be having sperms in the testes. Some of them are spontaneously fertile also. The others can be easily helped by extracting the sperm from the testes and using it for ART. So, but on the other hand, the A and B deletions are mostly having only Sertoli cell only condition, where you cannot retrieve any sperms. Testing is that these males are going to transmit the deletion to all their male offsprings, because the Y will always go to the male. So the child, a male child of such a person, will also have the same phenotype when he grows up. So the ones who get defects, we can also have certain translocations, inversions involving the chromosomes, sex chromosomes, as well as autosomes. So Dr. Seema has already alluded to these translocations, which can present with RPL, and they can also present with infertility. So usually in females, a female having a translocation more likely to have RPL, a male having a translocation more likely to present with infertility. So it is such one huge pedigree where you can see all the dark shaded males. These are all infertile males with sperm quantitative defects. And these triangles are the RPLs, which are happening to the females in the family. And here basically it's because of this translocation which is running in this family between chromosome 8 and 13, where a part of 8th chromosome has gone and got attached to the 13. This is the normal 13 and 8. And here you have part of the 8 attached over here. So what happens in these kind of translocations is, and when the meiosis happens, the gametes are going to get various combinations of these chromosomes, and some of them can be abnormal. And if these are abnormal, they can either present with infertility in a male usually, or it can present as RPL. It can also result in a baby who is born with an abnormal chromosomes and be intellectually disabled. So we need to kind of counsel these parents, and usually in a male where this is causing an infertility already, we would be going ahead with an ART anyways. So so in such a situation, if in ART is done, then of course PGT can be done, PGT SR, to look for the balanced zygote which can be transferred. So then we move. So these are all the quantitative defects we have covered. Now let's see the qualitative defects. So this is a lot of gray area, we could say, in the sense that for a large majority of these qualitative defects, we don't know the etiology, but there are certain phenotypes where there is a significant genetic contribution. So here is one such family. This is actually two Simpson. Both of them had infertility issues. They were born to consanguineous parents. And when more history was taken, it was found that they had additional issues like sinusitis, bronchiectasis. And so when the mutation analysis was done by an exome sequencing, they were found to be homozygous for a likely pathogenic variant in this particular gene, DNH5. So basically, this is primary ciliary dyskinesia. And this causes problem in motility. In the females, it causes tubal motility issues. In the males, it causes the sperm flagellal motility issues. So here again, basically, once you find this, you can you directly go ahead with ICSI in such a cases for the male part. So then coming to the kind of a summary. So what genetic tests are required in male infertility? So if you have azoospermia or severe oligozoospermia, whether hypergonadotropic or eugonadal, do a karyotype and do a AZF deletion. And when you have a CABVD phenotype, do a CFTR mutation analysis. If patient is positive, don't forget to test the partner before going ahead with the treatment. If the patient is hypogonadotropic hypogonadism, then we need to do usually NGS to sequence for these multiple other genes. If there is an androgen insensitivity phenotype or other genital ambiguities and all, then we usually need to focus in a different set of genes and work up accordingly. If there is a syndromic presentation, then depending on the specific syndrome, a particular test may be required. Finally, an important point to remember, even if it is unexplained, everything is looking good, sperm morphology is okay, sperm count is okay, still we should do a karyotype before going for ART. So very often nowadays we are saying patient has undergone ART, already some 6 embryos are stored, PGT is done, and the PGT report is showing that the embryos are having multiple chromosomal abnormalities because one of the parent has a translocation and nobody did a karyotype for that parent, for the couple, and directly they went through the whole process, and now they are directly coming with these embryos. So we need to remember that we need to do a karyotype even if there is nothing as such. And finally, just to touch upon this emerging area, so now there are, so as I was mentioning, these qualitative defects of the sperms, we are finding them very often in the semen reports. A large majority of them are lifestyle. But there are some specific phenotypes which, if you see, they again indicate a genetic etiology. So one is this large-headed multiflagellar sperm. Again, these are all very rare. And the other thing which is important to remember, that these kind of phenotypes sometimes maybe they're in like 5% of sperms, 10% of sperms. That doesn't mean it is genetic. Only if 100% of the sperms have this particular phenotype, then it is likely to be because of a genetic etiology, and then we can investigate. So there are certain genes which have a particular type of phenotypic presentation in the sperm, but here all sperms will have it. So you can have these round sperms, you can have these large sperm, you can have acephalic sperms, and you can have something called as MMAF, multiple morphological abnormalities of the sperm flagella. And then, of course, you have these actinozoospermic sperms, which again, we need to remember all sperms should be having it. Then only we need to do a genetic test, not in every case with these things. So these are some of the emerging things. Not all of these tests are clinically recommended at present. And in fact, even if you do it and if you find the mutation, most of the time the final treatment is ICSI. And if not successful, a donor sperm. So this testing as upfront may not always be clinically that much relevant. You can work on the morphology basis management also. So this slide just shows us that so many genetic contributions this is there for the male infertility, some of which is more strongly established, like the dark red ones. Some of them are less less evidence is there, and we need to study this further. And this starts right from the brain to the local, the genital area, and even at the level of the fertilization also. So finally, just to conclude, basically what we have seen that there is a significant contribution of genetic etiologies to male infertility. Identifying this helps in appropriate management, counseling. We can facilitate PGT or prenatal testing as relevant. And then, of course, with emerging technologies like next generation sequencing, we are able to also investigate some of the unexplained cases, and we may be able to offer more targeted therapies to these individuals in the future. So this I would end.
Thank you, Shagun. It was indeed a comprehensive understanding of the whole of the male factor of genetics in it. And the crux of the story states that before going in for any of the infertile treatment, if the patient is having oligospermia, severe oligospermia, do get the genetic testing for the male, karyotyping for the male, which is very important, or repeated RPLs if the patient is having, do check it for both the partners. Thank you for
Absolutely.
that elaborate and comprehensive talk. Thank you, Sita, for the opportunity. And
just take a few questions. I think they've asked, one was, what is QF-PCR for mosaic Turner? Any of you can take that. I mean, I don't know what they actually meant. Dr. Seema's here?
Yeah.
Or Dr. Shagun?
Okay, I can take that. I'm not sure. It was not, maybe it was irrelevant to something she said. So usually mosaicism, QF-PCR is not the right test to pick up mosaicism. Mosaicism is something when some of the cells have, here like for Turner, it could be some cells are having monosomy X, some cells are normal, disomic, like XX or XY. So typically such kind of mosaicism, we need to do either a FISH or we need to do a karyotype with a large number of metaphases. Then only we'll pick up these mosaicism. If they cannot be picked up on QF-PCR, they cannot also usually be picked up on a microarray unless the mosaic cells are larger in number, more than 20%. So I'm not sure of the context of the question, but basically QF-PCR is not the right test to look for a mosaic Turner.
I think Madam had presented a case where she had CMA was done on the fetus, which I think maybe in that context. But the other question is how to send a sample for CMA. I think for the products of conception, which Madam had mentioned. I can't see Dr. Seema. They're not able to increase I think she must have logged out and not able to join. Shagun, you can take that.
Yeah. So again, I think that, the next question also, to avoid contamination. It is difficult, of course, but it would be better to, one thing, use a medical termination rather than going for a DNC, so that you would get in toto the product, and then we can choose and pick. The lab can make sure that, they are able to dissect. There is enough placental tissue or fetal tissue, which they can kind of micro dissect and pick. So that would help in kind of avoiding contamination. So, and you could also wash the tissue in saline before, sending it across to the lab. But most of the good labs are able to actually dissect the tissue before they go ahead with the genetic testing. Same holds true for a CVS also. So we are supposed to basically dissect it under an inverted microscope, literally see each and every, if it is a placental tissue, the villi, and remove the RBCs from there, and then choose that and then use it for DNA extraction. So if it is done properly, at least, the rate of contamination is pretty low in good laboratories.
Right, thank you. I don't know if Shruti is here. People who have logged out are not able to join, I'm told, because the limit is, so they're trying to work.
Issues. So there's one more question. Would you recommend? Is there any role of carrier screening in preconceptional period? Routine carrier screening.
So again, this is not, an expanded carrier screening is not recommended at present in India. So our Society of Indian Academy of Medical Genetics, we have come up with the guidelines regarding carrier screening last year, December. So as of now, we recommend that universal carrier screening is to be done for only 2 conditions in India, that is thalassemia and spinal muscular atrophy. As far as expanded carrier screening is there, it is not routinely recommended for low-risk couples, but it can be done for specific scenarios. Suppose you have a couple who have a previous child or a previous fetus who had a suspected genetic condition and for whom we are not able to offer any testing. Child is not there, sample is not there. So in that situation, we could offer a carrier testing to the couple, assuming that they may be carriers of an autosomal recessive disease or the mom carrier of an X-linked recessive disease, which can explain the previous child's phenotype. And similarly, at least in South India, what we are seeing is that consanguinity is a very major factor contributing to couples both being carrier of the same disease. So at least in my practice and even our guideline, we have put that as a kind of a conditional recommendation or a conditional situation where we can offer carrier testings to consanguineous couples. Even without a family history, but they need counseling. Pre-test counseling is extremely important because when such kind of NGS-based carrier screening are done, there will be a huge list of variants of uncertain significance which will come, and then it will cause a lot of dilemmas for the patient. So pre-test, post-test counseling preferably by a clinical geneticist is what is to be done if we are offering expanded carrier screening in Indian context as of now.
I think we'll move on to the next session, Shruti.
Yes,
Thank you, Dr.
Moving on to the next session on fetal medicine, I would like to invite our chairpersons for the session, Dr. Kushagriti Ghosh. Sir is a teacher to many, and can I have the slide, please?
Shreya, can we have the slide, please? Yeah. Next slide. Thank you.
Sir is a professor at Kolkata University. He is also consultant obs-gynae at Woodlands and Neotia Hospital, Kolkata. He is director of Institute of Fetal Medicine, Kolkata. He is examiner in MBBS, MD, final MRCOG exams, and he has been thesis guide to many PG students. He is past president of Bengal Obs-gynae Society, and he is also past chairperson of AICC RCOG India East Zone. He is past president of Society of Fetal Medicine, Kolkata chapter, and he has conducted many live workshops on lab surgery, fetal medicine, CTG, and has published many papers in many national and international journals. And he has special interest in fetal medicine, genetics, and fetal therapy. Welcome, sir.
Thank you, Shruti. Am I audible?
Yes, sir.
Yeah,
yes.
It gives me great pleasure to invite Dr. Professor Ratnapuri, the professor in genetics and chairperson of Institute of Medical Genetics and Genomics, Sir Gangaram Hospital, New Delhi. We have been having interactions for many decades, I think, two decades or so. And she's an MD Pediatrics, DM Medical Genetics from SGPGI Lucknow, we all know. And she has received lots of awards, of which one is a very famous Dharamvir Award of Excellence in 2010. She had the Young Investigators Award, Tokyo, Japan in 2006. And she is the Undiagnosed Disease Network International of NIH member, Diagnostic Scientific Committee of International Rare Disease Research Consortium. And she is one of the panel of experts of WHO Collective Global Network for Rare Diseases. And she has a number of ongoing research projects under her belt. She has more than about 140 publications. And Dr. Puri, the floor is yours, and please talk through us.
Can you Post Madam slide, please. Yes. Yeah. Thank you so much.
Sorry, the slide was not there.
That's fine. That's fine. It's okay. Thank you so much for a very, very kind introduction. And thank you, Dr. Sita, for the kind invitation to be a part of this program. Somebody will have to stop sharing screen.
Yeah,
I am not able to. Yeah.
Thank you.
Are my slides seen? No?
Yeah, we can. We need to go near.
But not full screen.
Okay, okay. I'll have to do it this way. Now?
Yes.
Is that okay? Okay. Okay. So, without wasting much time, I'm going to, in the next 20 minutes, speak upon the topic I was asked to speak on, and that is rationalizing genetic tests for prenatal diagnosis. And I think when we think of genetic testing, it's
Veronica Arora is the co-host now.
It's like a bit of a genetic maze, but if we rationalize it, it becomes very clear. And I hope I'm able to convey that it is challenging, but I don't think it's very confusing if we are able to, get the concept of what to test and when to test. So the first thing about genetic testing and the diagnostic testing is, we know this is the darkest part of the population that we are dealing with, who need this confirmed diagnosis after this entire screening, whether it's biochemical screening or ultrasound screening or family history screening, whatever we have done has been done. We have a high-risk population, and it is to that high-risk population that we advise the prenatal diagnostic test, because they are invasive tests and they require expertise. So what are the general indications of diagnostic genetic testing? It is as a follow-up of an abnormality that is found on a routine ultrasound. So this really talks about a major malformation. If you have an isolated polydactyly, that's not an indication for doing routine diagnostic prenatal testing. You find a diaphragmatic hernia, you find a major cardiac abnormality. If you find a muscular VST, that's not an indication for diagnostic genetic testing. Maternal aneuploidy screening, whichever form it is, if it is screen positive, you want to do a diagnosis. Family history of a genetic disorder, or advanced parental ages. Why do we keep saying that think before we put in a needle and order a genetic test? Because there are challenges of interpreting genetic variants that are identified in the prenatal period, because there is not enough data that is available for that. There is a lack of the ability to phenotype the fetus because the fetus is still developing. It is possible that at that particular time, they don't have a phenotype, which they can develop later. And there is a pressure, a great pressure to make critical decisions because of an ongoing pregnancy, the timelines, and the fact that in pregnancy, at present, we are not able to correct anything, at least in India. And it is either continuation or discontinuation of a live baby. And therefore, I think it's very, very important to understand when to do the test and what test to do. Now, this is the array of genetic tests that is available. How do we decide what test? It is curated by the phenotype. And what is the question that we are answering? What is the question that we are asking? So when we want to look at chromosomes, we have these three options: karyotype, FISH, microarray. We do the methylation test for a specific group of disorders, which are the imprinting disorders. And when we come to the disorders that occur because of mutations in single gene, we come to targeted testing. And the lower part is the next generation sequencing, which could either be a targeted gene panel or an exome or a genome sequencing. And through some cases, etc., I'm going to take you through the host of them. The utility of a genetic test is, if there is a major abnormality and a genetic test confirms that there is going to be significant intellectual disability that has no treatment, then you can do post-test counseling, and there is an option for pregnancy termination. And I think everything I said has a meaning. I'm not talking about an abnormality. I'm talking about intellectual disability where there is absolutely no management. If there is something like as an appropriate in utero intervention, like now there are in utero enzyme replacement therapies that are coming up, and I'm sure over a period of time these things will come in India. But to be able to do that, you need a definite diagnosis, informing a delivery mode and access to a fetal sample. Supposing there's a major anomaly, they're discontinuing the pregnancy in a far-off place where facilities are not available, you have access to a fetal sample, which is very, very important. Now, before we do a diagnostic test, there is, as you'll hear in all genetic talks, and even Dr. Shagun alluded to that, something that's referred to as pre-test counseling, which should be provided by those who have appropriate training in genetics. What is discussed within that? What is the indication of the genetic testing? What sort of test should we do? Should we only test the fetus? Do we need to test beyond the fetus? When the results come in, what do we expect? We expect always a definite diagnosis. It's not that. More often than not, we get a variant which is uncertain. We don't know how to interpret it. And therefore, we have to discuss with them that these variants may not be significant today, but their variant interpretation changes over a period of time. And also secondary unexpected findings that are identified in the data that may have no relevance to the fetus at present, but these are findings that have implications for follow-up and treatment after birth. What are the implications of the result? A diagnosis is established or not established with certainty. There are specific ambiguities for fetal life genetic testing, and those are discussed. The timelines for testing. Very often there is a need for further testing. Limitations of the prescribed genetic test, because everybody thinks that there is one genetic test which will talk about all the genetic disorders. It's not like that. There are so many genetic tests. And the impact on other family members. Very often, even in the postnatal period, families tell us, please don't talk to everybody in my extended family about the genetic disorder. So you can see the impact that it has. So for various clinical scenarios, for example, if you have an abnormal genetic screening result for aneuploidy, you want to look at only the chromosomes. You could limit yourself either to a microarray or a karyotype. If we have fetal structural abnormalities that are consistent with a chromosomal disorder, a microarray is the preferred test, unless it's a specific abnormality like duodenal atresia. For these, if the array is normal and we think that it could be a single gene disorder, we could take it forward to look for that specific disorder, either by NGS or methylation studies. If there are familial genetic diseases and the mutation is known in the affected person, you just do a targeted testing in the fetus. You don't have to do a full exome. And the workup of a family member must be done before we test the fetus. And then you can have families where there is no abnormality, but they come and say, well, I just want things tested. In that situation, very, very significant pre-test counseling is required before any diagnostic testing is done. So whilst these are recommendations that have come from the Western community, we keep this as a backdrop. We don't follow them word by word because we have to tailor it to our requirements. Nothing is covered by insurance or by the state, and therefore it's very important to take in costs of testing and the outcomes for every patient. Now here there are two scenarios. This is a positive first trimester screen, risk for Down syndrome. We can just do the FISH and the karyotype. The advantage of doing the FISH is it gives a result in 48 to 72 hours, whilst the karyotype will take about 2.5 weeks for the culture and the reporting. Why should we not just limit ourselves to a FISH? Because you don't know what the FISH is going to bring forward. And therefore, sometimes the FISH results rarely may be ambiguous, and therefore a karyotype is required and you would need to resample then. So when you're doing an invasive test, this is the basic minimum that has to be done.
Second situation is this third trimester duodenal atresia. So here again, just a FISH and karyotype will suffice, because you know that what you want to look for in a fetus with duodenal atresia is Down syndrome. If the fetus does not have Down syndrome and the karyotype is normal, then the outcomes are good with surgery after delivery. You don't have to do extensive testing, so it is targeted to the question that we ask. What is it that the microarray provides beyond a karyotype? Now, this is a typical Down syndrome. Sorry, what is the information? If I could just minimize this. Yeah. What is the information that the karyotype gives us, which the microarray can't? The microarray will tell us all abnormalities. It will not give us whether the fetus has a free trisomy 21 or a balanced or a translocated trisomy 21 like this. However, in a fetus who has a structural abnormality, or if we want to look for Down syndrome, the presence or absence of an abnormality is enough to guide us. But in a parent, or where we only want Down syndrome testing, this will suffice, because this gives us an idea as to how it is free or a translocation. Now, for example, look at this family where you have multiple children with Down syndrome, no normal live baby, miscarriages. You should think of a translocation Down syndrome, where, and especially 21-21, where one parent is a carrier, and therefore in this family, they can never have a normal baby. And this is the one and only one indication where you can say that, well, do IVF with an egg donor because of the chromosomal complement of the mother. Because the mother would have a 21-21, and that two 21s will always go from the mother and one will come from the father. So these are some situations that need to be looked into. Beyond that, we look at the chromosomes in greater detail by doing a microarray, because that can detect smaller abnormalities of structure. It will detect all the abnormalities of number like a standard karyotype, but it will detect additional abnormalities of number because you're looking at the same chromosomes like you can see here with a magnifying glass. Then we've talked a lot about FISH and QFPCR. A FISH is a targeted test. I know that I want to look at only chromosome 21. I will put a probe for 21. It will not tell me an abnormality of any other chromosome. So if I suspect my fetus has a conotruncal anomaly, I want to look for 22q microdeletion, I will only use this FISH probe. That is the challenge with FISH, okay? However, the advantage of microarray, so this is just an example where you have a clinical situation of a conotruncal abnormality. You want to exclude 22q, whilst you will do advanced testing, but just doing a quick FISH to look for 22q microdeletion, that one spot you can see here it is present and here it is absent. The green is the kind of like control. You know, it's showing us this is where the two chromosome 22s are. And here it tells us that this little bit is missing because the signal is not there, and therefore this fetus has 22q microdeletion. The greatest advantage being it gives you a result in about 24 to 48 hours. However, the same result we can get on a microarray, but we could be in a situation where we think it could be chromosomal, but I don't know which chromosome is involved. So the advantage of a microarray is that it will look at all the 23 chromosomes together. And if there is something that is missing, it will flag that off. Okay. Another situation where it helps us is when on the karyotype we get this extra structural chromosomal abnormality. We don't know what it is. It could be absolutely normal if it does not have any significant disease-causing genetic variant in it. And this is one indication where we should do a microarray. If the microarray does not show any deletion or duplication, that means, and one of the parents may be carrying it, that means it is innocuous and less likely to be disease-causing. However, if the microarray shows, well, this extra part is a part like here of chromosome 15, an additional part of chromosome 15, which is very difficult to identify here, then we know that this is a microduplication syndrome associated with intellectual disability, and accordingly we guide the family. So the advantage of chromosomal microarray is that it tells us more, so it has a greater sensitivity. And if the chromosomal microarray is normal, the possibility of a chromosomal disorder is negligible, of missing any chromosomal disorder. However, there are challenges, there are specific ways, and a lot of expertise is required to understand what the copy number variants are. There are very often, and we have this situation very, very often, where we get certain variants of unknown significance. They could be deletions, they could be duplications, and there's not enough information world over for us to be guided as to, is that going to cause a problem in the fetus after birth or not? Very often, parents can be carrying a deletion or a duplication, and if the parent may be asymptomatic, but because the penetrance is variable, we still will not be able to say, will the child, when he's born, be asymptomatic like the parent or will have a problem? So therefore, a lot of expertise is required when we counsel for chromosomal microarray reports that come, because you can see that a large number of these are not disease causing. Okay, so not all copy number variants, even if they're not inherited from the parents, are not pathogenic, and therefore this counseling has to be done with a lot of care. And this is one example. A CVS was done for increased nuchal translucency and an absent nasal bone. The microarray showed a duplication in the long arm of chromosome 10. Now, we have databases. Now, this was not curated by the different databases, but then you go into these individual genes, that if these genes are duplicated, what is the triplosensitivity scoring? Okay. Now, a similar copy number variant has been reported in literature, but now we know that that variant is not disease causing. So this entire workup is required before you're able to counsel the families. It's a great test, but it's a test where the reports have to be discussed with the families with a lot of caution, especially if they are variants of uncertain significance or even pathogenic. Sometimes when we go into the details of the pathogenic reports, you realize that they may not actually be associated with disease in the fetus. These are the three indications for when microarray can be done, and I think everybody is aware of them, but it should not be offered without genetic counseling. Every abnormality on the array may not be pathogenic, and variants of uncertain significance require expert review and counseling. Now, there are also other kinds of genetic tests that can be used in prenatal diagnosis, because remember, prenatal diagnosis is something where you don't want to go wrong. So if there are disorders like metabolic disorders where we can do enzyme testing, and this is a host of disorders. So this is data from my lab in Gangaram. We usually combine the enzyme test along with the molecular test so that the chance of human error in reporting is minimized. So these are done on samples of the chorionic villi or cultured amniotic cells. Beyond that, if we come to these 20,000 genes, now look at this. This was a family where the test, they came for counseling for this triple test, but we saw that the unconjugated estriol is very, very low. You take the details of this family. There is a family history of ichthyosis. The PCR test done in the fetus and one of the family members confirmed the deletion of the STS gene. That's okay. You know why the estriol is low. You have a reason for the family history, but nobody here has intellectual disability. And therefore, even though that there is a deletion of a disorder, it's a genetic disorder, it does not warrant termination of pregnancy. There are many situations like this where the child has died without any form of testing and they have come in early pregnancy. You can't just take the fetus sample and do an exome. You have to first work with the family and try and understand what was this disorder. More often than not, the records have been thrown away. There is no fetal sample. But if you sit and give time, you will ask them question by question. You are still able to come to some form of a differential diagnosis. And it's what I call the Sherlock Holmes approach, because there is nothing else to go by. But there are times when you can help the families and you can do the test in the parents to at least fit in a thought process as to what you have to test that pregnancy. Once you have confirmed this in the parents, then doing a prenatal diagnosis is warranted. There are times now, there are easier way of doing that with next generation sequencing, but without this thought process, you still cannot apply next generation sequencing. The second test, which is, I think, very important for carrier screening, is for spinal muscular atrophy. Shagun introduced you to the concept of two things. When we should do the expanded, which is not recommended except in specific situations of high-risk pregnancies with a previous affected child and we don't have a diagnosis and you don't have sample of the child. But spinal muscular atrophy has a carrier rate that is as high as that of beta thalassemia. It's about 1 in 40. And therefore, the SIMG Society recommends that this could be a test that we can offer to couples. And this was the scenario where I was talking about. If the family mutations are known, this is a family with beta thalassemia, the carrier status has been worked out. In this fetus, you will only do the targeted testing. It is not at all necessary to do the whole gene sequencing. You will just do the familial variants for this fetus. Other situations like this, where this is a late in pregnancy, but there is a radial ray defect. The fetal autopsy was not done. The next generation sequencing shows a report that is partly consistent with the diagnosis, but we don't have a second variant. However, because a karyotype, now there are many differential diagnoses of radial ray defect, and Fanconi anemia is one of them. But because the Brackett studies, which is a specific type of karyotype, had been done in the fetal sample before the pregnancy was discontinued, we were very sure that this is Fanconi anemia and that this report had not confirmed the diagnosis. And so the quest continued until we identified two mutations in an absolutely different gene. Fanconi anemia can occur because of multiple gene mutations. And this deletion, when it was identified, now we have a specific diagnosis with which prenatal diagnosis can be offered. So this family, the fetus had Fanconi anemia because of a mutation in the FANC-CC gene, but was also a carrier for the mutation in the FANK gene, but that was not disease causing. But we were able to reach this because there was supportive evidence for the disease phenotype. So just sending off a next generation sequencing test at times does not work. And, before I conclude, I just want to make a point that it's not necessary that all disorders are diagnosed by NGS. We have to recognize phenotypes, and something like this, low-risk pregnancy but recurrent polyhydramnios, the baby is not able to establish breathing, and there was also a diaphragmatic hernia. We look at the parents, we do their carrier screening, identify that this is a GPI synthetic pathway which can present with multiple abnormalities. Only after this entire workup is done can fetal testing be done. Direct fetal testing by exome is not at all recommended. So the message is that you have to work up the family prior to prenatal testing. Targeted testing is done in the fetus. Now that was a novel variant, what we identified. It was not reported before. So you have to go back into literature. match the phenotype that is available for the fetus and see whether you think that the fetus, the children could have had that disorder. And this entire workup has to be done before a needle is put into the pregnancy. This is another situation where we can have antenatal polyhydramnios. They also will have problems at birth. This is something where your NGS will come negative, because in myotonic dystrophy, we have to do TP-PCR. It's a specific kind of a genetic test to confirm the diagnosis. And therefore, the test to be ordered is decided and directed by the clinical diagnosis after taking the details of the family and the phenotype of the affected individuals. Now, the biggest word of caution is doing exome sequencing in a pregnancy and getting reports like this, which are absolutely damaging. And any family with a report like this will end up in discontinuing a pregnancy. But when we individually evaluate all these variants, none of them are actually causing disease, and therefore, based on this analysis, we say that this is not possible, that these variants will cause disease in the baby after birth. And what was the indication of doing? Flat facies and a risk for trisomy 21. Situations where exome sequencing should not be done. And therefore, doing extensive genomic testing, the indication has to be very clear. Just finding any abnormality and sending off an exome is really not recommended. Because we know that every change that's reported is not responsible for a phenotype, and we can have these problems because fetal phenotypes also may not develop. And therefore, you really need highly tailored genetic consults to explain these WOOS results to avoid potential misuse of these tests. So these are the various kinds of genetic tests and the technologies in increasing order of expense, as well as the information that they can provide. The last green has to be used with excessive caution so that we do not do harm to fetuses. The test to order is based on the question to be answered. Unfortunately, there is no one-stop solution. We know that we have, most of the disorders are covered by the initial rapid testing. NGS does provide an additional yield of 30%, but for disorders which need to be tested by this, and not for any and every abnormality that is identified on the scan. So I have to tell you that this is a constant learning and an update. The interpretations keep varying. Something that was not significant 5 years ago can become significant today, but that is science. And therefore, we should only test when indicated and interpret these reports with a great deal of responsibility, because I think we are looking after an unborn child who has a right to come to life. And the concept of genetic counseling is very important. It has to be done by people who are appropriately trained in genetics, who know what are the nuances of these reports. Because every positive test does not mean that a pregnancy has to be terminated. So thank you very much.
Kushada, you're muted.
Yeah, I'm there. Thank you, Dr. Puri, for giving us a wonderful overview of genetic tests which to be done when starting from the very basic FISH and qPCR to the whole exome sequencing. And thank you for stressing the carrier screening for thalassemia and SMA in our country. And of course, the WES, the whole exome sequencing that we normally send, many of us send just a drop of a hat, is something which can cause more trouble than solving troubles. Now, regarding the whole exome sequencing, in antenatal pregnant patients, pregnant patients, when they come without any prior workup with an abnormal baby, we think that exome sequencing might come up with a diagnosis what should we be doing? Is there a possibility of doing whole exome trio in such cases?
So, no, I think the fetus should never be touched until we have evaluated the child who has the problem. I know the pregnancy advances, but it doesn't matter. You know, there are options that if there is a major abnormality, it can still be discontinued a little later in pregnancy. I think there is some echo.
Yeah, some error sound coming up.
Somebody got on
Two devices.
He has to unmute that.
But
Hello.
the affected child must be evaluated. And so if we do a good physical examination, make a differential diagnosis, there is a higher chance that we'll get some answers from the exome that is done there. In a fetus, if we are doing it for some fetal abnormality so there are very few fetal abnormalities where you'll really need to rush in and put in a needle. Okay. Cleft lip palate, where there is a possibility that they will continue the pregnancy if there is no genetic disorder. CTEV. And this is also after we have excluded chromosomes, ventriculomegaly. So these are very few situations where I can think that we need to really put in a needle and do an exome. If you get something like an abnormality of the ductus venosus, like the ductus venosus is not draining, it's displaced lower, they are not indications of doing exome. You just have to exclude chromosomal disorders. So I think what is relevant is every time there's an abnormality, we have to go back to literature, review what are the associations. Whenever we review something, we have to take the whole picture, not that there is one paper that is reported with one genetic abnormality in this. In that situation, I do not advise testing. I mean, I feel very strongly about it because now I spend every OPD sorting out WOOS reports. And there are very few of them where I say that, yes, this is abnormal. Most of them are benign. So, and look at the expense the family has gone through, the trauma the family has gone through. And I'm sure that my word is not gold. I'm sure that they are still worried till the baby is born and after the baby is born, and they keep following up the child. Will my child have an abnormality? I think it's fine. See, I think we've forgotten the whole perspective. 95% of the families pregnancies are normal. In 3 to 5%, we can have abnormalities. 30% of them are picked up by fish. Yeah. Another 5-10% are picked up by microarray. You are left with a small residual risk. So if you have major abnormalities or these sort of abnormalities where the postnatal outcomes with surgery are good, I think those are the ones that we need to target. We should not do it for a normal kidney, which is ecogenic. We should not do it for a polydactyly. Problems may come up later. You may see the encephalocele later. We'll think about it then. But if you get a worse variant in Meckel-Gruber or Bardet-Biddle, even I will not be able to tell you that that is going to cause disease. And nobody will be able to tell you.
Thank you, ma'am, for explaining in so details. Now, there is a question over here. A first baby albinism, suffering from albinism, and she's currently pregnant. How to go about it? The trimester has not been mentioned. Let us suppose it is first trimester.
So we will first test that albino baby. Now, if the baby is absolutely depigmented and white and there is no pigment in the eye, it is most likely tyrosinemia type 1. Majority of them occur because of one mutation. And so we can quickly just order that targeted mutation. It will come back in about 10 days to 2 weeks. But if there is some pigment in the baby, then in those situations, we will have to do an exome because there are about 4 genes that can cause tyrosinemia. So it could be not tyrosinemia, oculocutaneous albinism, type 2, type 3. In type 1, there will not be any pigment at all. So that's how you have to do it.
Right. And Sita, would you like to take off from here?
Yeah, I don't think there are any other questions here, but just a request for other delegates to share the YouTube link, which has been shared in the chat box, so that other delegates can join. There's been an issue, I think, with the limit here. So there are a lot of people who want.
Difficult to join in. I was first not able to join.
So we shared the
100.
YouTube.
Yeah.
And thank you, Madam, once again for accepting our invitation and giving this fantastic talk as always. Thank you so much for your sparing your time. Shruti, if you can introduce Dr. Geeta Balsarkar as the chairperson, we'll introduce Dr. Chinmay. Thank you. And Dr. Veronica, Dr. Krishad Ghosh will introduce her again. Thank you.
So moving on to our next topic, genetics of hemoglobinopathy. And we would like to welcome our chairperson for the session, Dr. Geeta Balsarkar. Ma'am is a professor, unit chief at Norsoji Wadia Maternity Hospital, St. Julius Medical College, Mumbai. She is secretary, Mumbai Obs Gynae Society. She is past editor-in-chief.
Yeah, Shreya, go back.
Yes.
Go back on your slides.
Yes,
yeah.
Yes. She is past editor-in-chief of Journal of Obs and Gynae Society of India. She is past president, Association of Medical Women of India. She is president of Mumbai Menopause Society. She is chairperson of Young Talent Promotion Committee of FOXY. And she is also recipient of Hargobind Foundation Fellowship for Study of Fetal Medicine in 2008. Madam, please welcome.
Thank you, Sita, for inviting me here for this very, very interesting topic. Can I have the biodata of Dr. Chinmay Ratha, please? Yeah, Dr. Chinmay Ratha actually does not need any introduction for this audience. She is MS Obstetrics and Gynecology, FRCOG from UK, Director and Lead Consultant of the Resolution Center of Fetal Medicine in Hyderabad, Senior Consultant Fetal Medicine on OB/GYN at Kim Sunshine Hospital, Hyderabad, and she is a Center Head ICOG FM certification course, approved examiner in MRCOG Part 3, and is also a peer reviewer of Jogi and the Journal of Fetal Medicine. She has had a lot of awards and publications to her credit. Chinmay, I invite you here to make your presentation.
Thank you so much, Geeta ma'am. Thank you. And thank you, Dr. Sita, for this opportunity also. And it's really a thrilling experience to see that the more and more people want to join the webinar, which is usually the case when we are looking for an audience, and this seems to be a real hit from you. Can I share my screen, please? So it's a rare honor to speak after Dr. Ratnapuri in genetics in India, because Ratna ma'am is supposed to be the final word in genetics in India. She said her word is not gold, but I beg to differ, because she has saved a lot of fetuses because of her practical and sensible approach to genetics, which is what we need now. So the topic I have been given is genetics of hemoglobinopathies. Now, I am an obstetrician. I'm not really a geneticist. So I had a friend who had a patient who had a hemoglobin of 7 gram%. And we are all very worried with anemia in pregnancy, because anemia is bad and it causes a lot of complications. So the first line treatment for anemia that we think is iron preparations. She gave her iron preparations. It didn't work. Then she gave her a deworming protocol, encouraged her to take iron-rich foods, and her hemoglobin remained low. So finally, she was given total dose iron infusion, multidisciplinary management, and somehow they took on the pregnancy to term and delivered a 2.75 kg girl baby who was apparently healthy at birth. And the team congratulated each other because they thought they had really done good with her obstetric patient. Now, 8 months later, the parents returned with the baby, and the baby was having persistent anemia. There were need for frequent blood transfusions, and the baby had now been diagnosed with thalassemia major. So where did we go wrong? Where we went wrong was the mother actually had thalassemia minor, and now this baby has had thalassemia major. When you think of hemoglobin or iron deficiency, you think it's a deficiency of hemoglobin altogether. But hemoglobin in itself is a complex molecule which has a combination of heme and globin. And at different levels, there are subunits of this globin which may be malformed, and there may not be a deficiency of hemoglobin per se, but there may be a defect in the hemoglobin. And that is the category of diseases which we call as hemoglobinopathies. And this thalassemia major is nothing but another hemoglobinopathy. Now, where did we go wrong? What we did not understand that anemia can be a combination of both lack of heme or lack of globin. And in this case, it was definitely a problem in the globin chain rather than the heme. So what we were doing was we were overloading this woman with, iron, which would actually have been counterproductive for her. So why did we not understand this? Because when we look for anemia, we do a CBP, a complete blood picture. But we concentrate at only one thing, and that is the hemoglobin, the actual amount of hemoglobin. And if that amount is normal, we think everything is normal. But there are other things in that entire report which may lead to a diagnosis that is more refined than pure anemia. And that is the other factors, which are the, mean corpuscular volume, the mean corpuscular hemoglobin, the mean corpuscular hemoglobin concentration. And if you look at these things, and despite having a hemoglobin of 11, the MCV is only 69, the MCH is only 21. You know that somewhere things are not optimal. There is a degree of microcytosis, there is a degree of pallor in each RBC. And therefore, when you go ahead and do a more refined test than a CBP, you get different types of hemoglobin and their distribution. So the two common tests that I use for screening is hemoglobin electrophoresis or high performance liquid chromatography, where you look at the peaks of the different types of hemoglobin that you have, the subdivisions of hemoglobin that you have, and you look for a peak of hemoglobin A2, which determines the possibility of thalassemia, beta thalassemia. So hemoglobinopathies are nothing but inherited disorders of red blood cells, and the major two groups of hemoglobinopathies are thalassemias or the sickle cell syndromes. About 7% of the world population carries an abnormal hemoglobin gene, with almost 3 lakhs to 5 lakhs children born every year with hemoglobin disorders. And if you look at hemoglobinopathy per se, it is one of the commonest autosomal single gene disorder when you look at the global perspective. So it is important that we have to understand the entire perspective of hemoglobinopathies. What I am going to discuss today is the genetics of these hemoglobinopathies. So most of these hemoglobinopathies are carried as autosomal recessive condition. So when that condition is recessive, you need two abnormal genes for the condition to become manifest. So if the condition is manifest, you know that the person has two abnormal genes. But the sad part or the difficult part or the scary part is there will be a lot of people who will not have any manifestations, which may be very obvious, and will be carriers. So you call them asymptomatic carriers. Now that woman with a 11-gram hemoglobin could have been an asymptomatic carrier, but the woman with a 7-gram hemoglobin was partially symptomatic. We just didn't look at the symptoms very carefully. So a carrier father and a carrier mother carry one normal and one abnormal genes. So if you remember the Mendelian laws of inheritance of the law of segregation and the law of independent assortment, all these, genes will become segregated at the time of reproduction and will have independent reassortment. So this father will have one normal and one affected gene. This mother will have one normal and one affected gene. And when they will form these offspring, one of them will have both the normal genes, and two of them will have one normal and one abnormal gene, and one of them will have both the abnormal genes. So 1 out of 4 times you may have a child who has both the abnormal genes, and hence 25% chance of having an affected child if both the parents are carriers. And that is practically true for all the hemoglobinopathies. So what went wrong with Mrs. Pale, the first lady that we were treating for a hemoglobin of 7? Despite our best intentions, we did not understand that there was a genetic etiology. Unawareness of genetic etiology is one of the main reasons of problems. Like Ratna ma'am was saying, in many conditions, one, we are over testing for everything that is possibly genetic, but the other aspect is also being unaware. So if a child has neurodevelopmental delay for a long time. Before all these genetic tests came, it was attributed to perinatal asphyxia and no genetic tests were done. And when the recurrence was repeated, then one would understand that it could be genetic. So unawareness of genetic etiology. How many of you actually get an HPLC or hemoglobin electrophoresis done for your patients before you start treating the anemia? I can't get your live answers here, but I would like to ask all obstetricians, please make it a point to at least do a basic hemoglobinopathy screening with an HPLC or an hemoglobin electrophoresis in pregnancy, just to rule out the carrier status of that one woman. If you rule out her carrier status, then the possibility of getting a hemoglobinopathy in the offspring is almost gone. So in this case, there was unawareness of the genetic condition. There was unawareness of the sequelae of the genetic condition. And we landed up in a situation where the offspring had a major thalassemia. And that was something that we could not detect prenatally. So despite our best intentions, harm was done, and the fact that prenatal diagnosis is possible in hemoglobinopathies. So in beta thalassemia, that is a gene that is found on chromosome number 11, and both the copies have to be abnormal for the child to have abnormality. If only one gene is abnormal, then it will just be a carrier and not a affected person. The moment we say genetic conditions, everybody looks at this picture and thinks this is the be all and end all of genetic testing. And so when parents with previous child of thalassemia go to an obstetrician, usually a karyotype is advised for them. And then they are told that they have done the genetic test and you are normal. So please remember that a karyotype cannot detect thalassemia. Double marker test is a screening test for Down syndrome and not for thalassemia. So when the first child has a hemoglobinopathy, the screening of the parents is by hemoglobin tests, genetic screening is by genetic tests, and prenatal diagnosis is also by genetic tests. It is not by this test called karyotyping. Just now we were informed, Ratna ma'am gave us a whole array of whatever tests are available. And karyotype is not the test for hemoglobinopathies. Genes are strands of DNA. Chromosomes are, a concentrated collection of all the genes in one structured manner. But when we have to test for a genetic condition, you have to open up that chromosome and look for that particular gene which you're looking for, and open up the strands of the gene and actually read the codes on the gene to see whether the gene is correctly formed or not. And like I told you, the gene for hemoglobinopathy is in chromosome number 11. And for all these problems, primarily the screening happens by history. But in hemoglobinopathies, if you want, apart from history, just the awareness that mild anemia could be the only presenting feature of a carrier, and the fact that a simple test like hemoglobin electrophoresis can be done to check for the carrier status is good information for all obstetricians to use as a screening test. So the locus of the gene is the place site on the chromosome where it is found. And as I said, the gene for hemoglobins is in chromosome number 11. And therefore, all these problems, they are somewhere on that chromosome. There are about 4% of silent carriers, and 1 in 25 Indians could be a carrier of hemoglobinopathies. There are certain communities which have a higher concentration. But considering the social, mixing in the last few generations, where people have migrated from one place to another because of jobs, people have married people from other people as they fell in love with them or whatever the reasons. So now we really cannot classify one ethnicity. It really makes sense to screen every pregnant woman for a possible carrier status of hemoglobinopathy. So this is something which all of you should remember, that the mother and father can be phenotypically normal. They may look absolutely normal, but if they are carrying the hemoglobinopathy gene, 1 out of 4 babies could have the major hemoglobinopathy. And that is a very, very debilitating disease, because if you don't have any normal genes, the amount of hemoglobin that you will have will be very less. There will be premature, breakage of the red blood cells, hemolytic anemia. And at some point in time, there will be a failure of functions and requiring multiple blood transfusions, and sometimes things like bone marrow transplant or splenectomy and problems like that. So we need to look for hemoglobinopathies very aggressively in pregnancies. Now, there are four units in the globin molecule, which are 2 alpha chains and 2 beta chains. And depending on which chain is getting affected by the mutation, we will have either an alpha thalassemia or a beta thalassemia. So alpha thalassemias result from the deletions in the globin chain for the alpha subunit. And what happens here is there are two varieties of this kind of problem, where one where you will have a complete deletion of all the alpha subunits, and one there is a partial deletion, or because there are 4 genes involved here, the heredity is a bit complex. So you may have an extremely lethal variety where you may actually land up in hydrops fetalis in the fetal condition, or there may be a very, very mild form of the disease, which will just be like a trait and not affect the life of the individual per se. So what happens in alpha thalassemia is either there is a deletion of a large fragment of the gene, or there are point mutations in some of the areas leading to an abnormal variation of the alpha globin chains. So there will be a genotype and there will be a phenotype. The one where there will be absolutely no alpha chains formed will lead to a formation of an unusual kind of hemoglobin known as the Bart's hemoglobin, and that variety presents as hydrops fetalis. So recurrent hydrops fetalis, one of the causative factors is alpha thalassemia of this Bart's variety. In the other conditions, if you can see, there will either be an alpha plus trait or an alpha 0 trait and a different kind of hemoglobin H disease, which may lead to variable presentations like mild to severe anemia, as well as jaundice and splenomegaly. So how do we do prenatal diagnosis for alpha thalassemia? It is either through a test that looks at that deletion or through a sequencing of the entire gene. And therefore, you can do tests like MLPA, multiplex ligand based probe assay, and Sanger sequencing of the particular gene that you're looking at, or next generation sequencing kits are also available to look for the variations in the hemoglobin gene that cause the alpha thalassemia. Which test to apply will depend on what you are looking for. And like Dr. Ratna said, before planning these tests, we must talk to the geneticist. And, even if you know that it's thalassemia, even thalassemia has so many varieties, and even alpha thalassemia has so many possibilities. So don't just write test for thalassemia, but give them the exact test that you're looking for so that a particular diagnosis can be established. So when you talk about beta thalassemia, again, it's the same situation where both the parents are carrying a disease gene, and there is a 1 in 4 chance of the disease being inherited as a major thalassemia by the child. And it does not matter whether the child is a girl or a boy, because here it is an autosomal recessive inheritance. This is not sex-linked. This is an autosomal recessive inheritance. So in the beta thalassemia, there are different varieties of this beta thalassemia syndrome, depending on if there is any other hemoglobin variation associated with the thalassemia gene. Knowing that 1 in 25 people may be carriers of beta thalassemia gene, you may have the abnormal varieties of hemoglobin also coexistent, and that can lead to a variety of syndromes. Hence, it helps if we do a proper hemoglobin electrophoresis in all our pregnant women, so that we detect any of these unusual hemoglobins right at the outset of pregnancy, and then the management of the future of that pregnancy becomes much easier in terms of the hemoglobinopathy. Sickle cell trait is another common hemoglobinopathy that we see. And if there is a combination of beta thalassemia and sickle cell trait, that can become again a major hemoglobinopathy. Sickle cell is also inherited in a autosomal recessive manner. And although here it is very simple, the genetics, because we all remember from school days that there is a, there is an exchange of a particular amino acid where glutamic acid is replaced by valine, and that leads to this kind of hemoglobin which sickles whenever there is a low hemoglobin concentration or change in the pressures, and therefore that can lead to sickle crisis in people who are affected by the sickle cell anemia. So how do we check all these things prenatally? Prenatally, we can do tests like amniocentesis or chorionic villus sampling and get fetal DNA for analysis. When we get fetal DNA, we know what we are looking for, and we ask the lab to check for that particular variation. So first, we must have established the primary diagnosis in the parents. So we know what they are carriers for, and we are looking for that combination in the fetus. So the fetus can have 2 normal genes. In that case, the phenotype will be normal and the genotype will be normal. So in that case, we don't need to worry at all. If the fetus has 1 normal and 1 abnormal gene, then the fetus will be phenotypically almost normal, because carriers are generally asymptomatic. They may be having mild anemia, but as a genotype, this person will be a carrier, and this is important for his or her future reproductive potential. The third option is when both the genes are abnormal in the fetus, and in that case, the fetus is genotypically abnormal or whatever, homozygous for that condition, and it will be definitely affected phenotypically because it has no normal gene for hemoglobin. So prevention is a far, far better strategy than actually trying to do a prenatal diagnosis and eliminate the fetuses that have a homozygous condition. And primary prevention has been achieved in some places, although they are geographically very small. And Cyprus is an example where primary prevention of thalassemias was achieved by screening the people at the time of marriage and not allowing marriage for couples who are otherwise carriers. That could have been possible in that country. It may not be possible in a huge country like ours with so many cultural barriers, but then that's something for a food for thought. So this is Mrs. SK, 27-year-old G2P1L1 in a consanguineous marriage. And the first child had anemia diagnosed at 3 months of life and needed multiple transfusions. Then it was found out that the first child had beta thalassemia. Both parents were then tested. They were found to be carriers. So again, like I said, they were asymptomatic, but they were carriers. And in this particular pregnancy, because we knew that both the parents were carriers, CVS was done and the child was found to be either normal or affected. My point to give this case is that is the standard protocol that we will follow for prenatal diagnosis of hemoglobinopathies once we are sure that both the parents are carriers. In this condition, first child was affected, unfortunately, and we came to know only after that. But today, if you want to do primary screening, you can do HPLC of your mothers. And if they are carriers, get the HPLC of the parent, of the father. And if he's also a carrier, then you need to do prenatal diagnosis. This will give you a definite report and you can be happy. However, every time genetics is not like a plain Rubik's Cube and things don't go on so well, because we forget the basics that we must be screening and doing appropriate pretest counseling for all people who are at risk of genetic conditions, and we forget that. If we try to do carrier testing in the antenatal period, it would be very, very useful, but obstetricians, parents, everybody has some or the other excuse, and they try to avoid doing this kind of screening testing. And therefore, we have just achieved about 5% of prevention, although about 95% is possible. So this is a couple who have just come to us recently. And if you see, the hemoglobin electrophoresis report in the parents showed a different combination. The mother was carrying a gene for, say, sickle cell anemia, and the father was carrying a gene for thalassemia. So if you look at just one condition, for example, if I had seen that the mother was a carrier of thalassemia, and I had tested the father only for carrier status of thalassemia and found that he was not a carrier of thalassemia, I may have missed the fact that the father could be a carrier of hemoglobin for sickle cell anemia. So it is better to do the proper hemoglobin electrophoresis for both the parents and try to look for any hemoglobinopathy carrier status. Now we have one person who's a carrier of beta thal and one person who's a carrier of sickle cell. So what is the possibility? The possibility here is, again, by the same segregation and independent assortment, the 1 out of 4 children might receive 1 gene from sickle cell from a parent and 1 gene from thalassemia from a parent. So they will have only 1 gene of thalassemia, but they will not have another normal gene. And therefore, this will lead to a condition called compound heterozygosity. And that also is a major hemoglobinopathy. So not only they have to be carriers of the same hemoglobinopathy, they can be carriers of different hemoglobinopathies and still have affected children. So compound heterozygosity is a possibility, and that is why we need to have proper screening of hemoglobinopathies for both parents whenever one of them is found to be a carrier. Now, this is a lady who's 26-year-old, having severe chronic anemia, repeated transfusions, and she herself is a compound heterozygote of sickle cell and beta thalassemia. She's already had a splenectomy and she's on constant follow-up with a hematologist. And now she has become pregnant and she has been referred to us for prenatal diagnosis. Can anyone tell me what prenatal diagnosis should I do in this condition? I had a lot of pressure from the obstetrician that please do a CVS, please do an amniocentesis. But I really did not want to do anything in this case because this mother herself is a compound heterozygote. So she has one gene of S and one gene of T. That means she has either a sickle cell gene and whatever she will contribute to the gamete will be either sickle cell gene or thalassemia gene. Everything depends on the carrier status of the partner. So if the partner is normal and does not have any hemoglobinopathy, then I need not do any prenatal diagnosis because all the children will be carriers of either sickle cell or thalassemia. They will definitely inherit one normal gene from the father and the mother will contribute either sickle cell or thalassemia gene. And therefore, there will be 100% carrier status for which I don't need to do an invasive prenatal diagnosis in a pregnancy like this. However, if the father would have been a carrier of either sickle cell or thalassemia, then there is a 50% chance of inheriting one of the hemoglobinopathies as a homozygous condition, and then I would have done the test. In our case, luckily, the father was not a carrier of hemoglobinopathy, and therefore we did not do any prenatal test. The child was born as a carrier of sickle cell anemia and is doing very well because there was no need for any prenatal diagnosis. So understanding the genetics of hemoglobinopathy is very important. Screen always. Test whenever applicable. Please don't test everybody just because the parent is a hemoglobinopathy carrier. So compound heterozygosity is very, very interesting. But at the same time, you need to understand it. If the husband is normal, children will only be carriers and the mother does not need to be tested. So we will be encountering more and more of these genetic issues in our fetal medicine clinics, and therefore we must have a thorough knowledge of the basic principles of inheritance, try and update ourselves on the new diagnostic potentials, and work in close coordination with a clinical geneticist. Whenever possible, index case molecular workup should be done because there are about 29 mutations that are known for beta thalassemia. So doing the mutation analysis of the index case helps, although it is now such a nicely worked up scenario that even if you don't have an index case workup, do not delay the prenatal diagnosis just because of that. The labs are able to handle those issues. Preconceptional and interconceptional investigations are ideal to plan prenatal tests because in pregnancy, you're running against time. So if you're able to do all this workup in the preconception and interconception period, that is really ideal for the couple, and expect the unexpected. So please do not let any of your pregnant women go away without having a basic hemoglobin electrophoresis. You may not find everything, you may not be able to explain everything, you may not be able to prevent everything, but do something because if doing nothing is no longer an option. Thank you so much for a very patient hearing.
Thank you, Chinmay. That was very, very complete, and you have dealt with all aspects of hemoglobinopathies. I had one question. Sometimes when we test patients by interventions like say CVS or amnio, we do karyotype. So when you are testing patients for thal or sickle for that matter, do you do a karyotyping as well for these patients?
Thank you. Thank you for the question, ma'am. It is actually a very important one. So the patients who already are aware that they have to have a CVS because of thalassemia. So we don't do the routine screening test for them for Down syndrome. What we do is we take out the CVS sample and we tell the lab that first you test for the thalassemia because there is a 1 in 25, 1 in 4 chance that we might get thalassemia. If we do not get major thalassemia, that means if the genetic testing result is favorable, then with the stored DNA, we at least run for a FISH or a QFPCR for Down syndrome. If the parents are willing, they can do a full microarray. But since there is no other indication and only we want to rule out major aneuploidy, for trisomy 21, we do the QFPCR.
Yeah, thank you, Chinmay, because quite a is involved. So sometimes parents are not willing to do the additional karyotype, but it is always sensible. And if the parents are counseled appropriately, I think once we have material, it is better to test for the others as well.
Yes, ma'am.
Thank you. Over to Sita.
Yeah, thank you. Thank you, Chinmay, for that excellent talk. And she has a flight to take, so I'll let her go. I don't think there are questions. But Dr. Veronica is here. So Dr. Ghosh, if you can please introduce Dr. Veronica for her talk. And
Yeah,
thank you very much for
can we
joining.
have a PG slide, CV slide?
Good evening, sir. Good evening, ma'am.
Yeah, good evening, Veronica. Yeah. Sure. Veronica, we all know she's a consultant in clinical genetics at Sir Gangaram Hospital, and she has done her MS OBGYN from Kolkata, and then she has done a DNB and super specialty in clinical genetics. She was a gold medalist in that, and she has a lot of affiliations. She has a lot of papers, and we have heard many times from her regarding various aspects of clinical genetics, and she makes it very simple. And she has a lot of affiliations, as I said, secretary of a Delhi chapter of Anbai and the head North Zone Ispat Society Advisory Board of the Myositis Society of India, member of the Unimed Initiation for DBT, published more than 60 papers. She is a treasurer of the Delhi Society of Fetal Medicine and executive member of Society of Indian Academy of Medical Genetics, and the list goes on and on and on. She's a FOGSI accredited co-editor of FOGSI Focus on Fetal Medicine and Genetics. Her areas of special interest are reproductive genetics, RPL, fetal malformations, autism, skeletal dysplasia, and dysmorphology. And she's going to talk to us on PGT in infertility. Yes, Veronica.
Thank you, sir. Honored to be introduced by you. Thank you, ma'am, for having me here today. So, I'm just trying to share my slide, but I'm not allowed to. So, Chinmay ma'am, if you could unshare your slides.
It's already unshared, Veronica.
Okay, ma'am. Okay.
Yeah.
Okay, thank you. So today I'm going to talk about pre-implantation genetic diagnosis and testing and what's new in the field. So since the introduction of this term PGT in assisted reproductive technology, it has become a routine application for examining aneuploidies, genetic disorders, and chromosomal disorders. The terms previously that were used to refer to PGT were PGD, that is pre-implantation genetic diagnosis, as well as PGS. Now we have replaced this and using pre-implantation genetic testing with its various reforms. So these terms were recently replaced by the PGT in the European Society of Human Reproduction and Embryology, following a revision of the terminology in infertility care. The terms were revised to PGT for aneuploidies, PGT.
You are the co-host now.
PGT for monogenic disorders, what we call as PGT-M, and PGT-SR for chromosomal disorders. Although the tests have been renamed, based on the data collected throughout their history, these tests still mainly are used by couples with advanced maternal age, recurrent pregnancy losses, recurrent implantations failures, or a family history of genetic disorders. As we can see in this chart, which is taken from a paper recently published in a leading journal of infertility, it says that conventional PGT and emerging PGT technologies can be divided into two parts. If you look closely, we can see that conventional PGT technologies again include PGT-A, that is formerly referred to as PGT-DS or PGS, that is screening for aneuploidies. Then PGT-M, that is PGT for monogenic or single gene disorders. Then PGT-SR. Then we have emerging technologies for the same that are still not really being used very rampantly, but that's what we need to look out for, and especially my topic for the day, that is the newer technologies of the same. So PGT Plus is an integrated technology of PGT-A, PGT-M, and PGT-SR. NIEVT is non-invasive embryo viability testing, and PGT-P is PGT for polygenic disorders. Polygenic disorders, of course, are those which are multifactorial and are caused by more than one genes, for example, a neural tube defect, a club foot, etc. So moving on, this is the timeline of PGT and how different tests were introduced and how the technology has improved from testing by a simple PCR with its so many fallacies and so many errors, with now coming on to even further than NGS, that is long read sequencing. So in about 1990, the PGT-M was first introduced when it was known as PGD, and we started by the technology of PCR. PCR has a lot of fallacies going on, and because we are running these cycles each time, there is a error rate that is present. Again, we cannot pick up mosaicism, we cannot pick up very small mutations by this PCR technique. Further on came the technology of FISH for testing the same, but we could only do a targeted testing with FISH in about early 2000s. Then by this FISH technology came the use of PGT-A, that is PGT for aneuploidy testing, much like what we do in your amniotic fluid testing. FISH was used for PGT-A or PGS as formerly known, but we could only look for certain specific aneuploidies. With the advent of array-CGH, a lot of these problems were solved. In approximately about 2003, early 2000s, array-CGH was introduced, and it helped in picking up abnormalities, copy number variations of most of the chromosomes very confidently, even in embryos. Then came SNP array in about 2005, where as compared to the array CGH, we had a better sensitivity, we had a better pickup rate of even the mosaic embryos. So mosaicism was much better picked by the SNP array. The triploides, the polyploides were picked up by SNP-based arrays, which were actually missed by array CGH. Of course, NGS has revolutionized genetics in more than one ways, and so it has revolutionized PGT itself also. With the advent of NGS in about 2007-2008, we could now pick up smallest of variations, and then is what came the proper introduction of PGT-M and even non-invasive PGT in this setting. Long read sequencing is a modification of next generation sequencing itself, and it has now enabled the non-invasive pre-implantation genetic testing. So this is what the PGT really looks at a glance, and how it has revolutionized and how it has become better and better as the time goes, and how the need for confirming by invasive testing has decreased much more than before. So let me just give you a basic idea of all the three important parts of the PGT that exist today, and a little bit brief then about the modifications and the newer variations in PGT that exist. So number one is PGT-A, also referred to as PGS, that is pre-implantation genetic screening. It is a definitive tool for embryo selection based on the euploid status, and it was previously known as PGS. According to the latest published guideline, it is recommended in certain patients of advanced maternal age, recurrent miscarriages which are occurring due to unknown causes, and recurrent implantation failures, and of course unexplained severe teratozoospermia. So AMA, or advanced maternal age, is the most really well studied application of PGS. PGT-A embryos, there are several ways really to screen them based on number one, that which chromosomes are we looking for? Are we looking for some specific chromosomes, or we want to look at all the chromosomes together? So today, array-based CGH and SNP array technologies are the most common technologies that are being used to perform PGS testing. So a chromosomal microarray that is being done in amniotic fluid is something that we do on an SNP based array on the embryo DNA to look for any chromosomal variation in the embryo to have a better result of IVF technology. Owing to the dramatic development of NGS, this technology has been introduced as the state-of-the-art approach to aneuploidy screening, characterized by its high throughput, low cost, high sensitivity, and high specificity. Various studies have now validated the accuracy of NGS for comprehensive chromosomal screening of embryos and has established its diagnostic yield to be almost 100%. So at present, it is the gold standard for PGS testing and has now superseded SNP-based array or array CGH for the same. So PGS is now being done by NGS technique due to its high diagnostic value. Now we come on to PGT for monogenic disorders. We know that pathogenic variations or mutations in a gene causes what is known as monogenic disorders. So PGTM is critically needed to prevent congenital abnormalities so that the burden of abortion miscarriages also decreases in a population. Theoretically, PGTM can be used for all monogenic disorders with unequivocal identification of pathogenic loci. However, the severity of the disease and the actual situation of the visiting family must be actually and comprehensively studied. A single gene disorder causing polydactyly, does it deserve a PGTM? Does it deserve a pregnancy termination? These questions, the financial condition of the family, these questions need to be answered before we can offer or even talk about PGTM to couples and families. We are not looking for a designer baby. We are just helping carriers of couples with pathogenic variants and serious genetic disorder to prevent a child with a disability. Indications for PGTM include X-linked disorders like DMD, dominant single gene disorders like Huntington's, recessive single gene disorders like cystic fibrosis, and even mitochondrial disorders like Kearns-Sayre syndrome. So important point here to remember is that the PGTM includes testing for monogenic as well as mitochondrial disorders. So this is a combined term which was earlier used separately for the same. HLA typing is also an indication but seldom used in India. However, indications of PGTM should also be highlighted. A mutated genes must have a family with a clear pathogenic or pathogenic gene linked marker. We need to be sure that this mutation is causing this disease before we can go ahead and offer the same. The diagnostic PGT approach has markedly evolved over the past few years. Now, at present, we are using the STR markers with or without targeted amplicons and the NGS techniques called the haplotyping method, which has been the gold standard earlier, but now it has been replaced by the NGS-based technology. To overcome the potential problems that existed in the STR markers technique, NGS has now replaced all the testing that was done earlier with the high throughput technique that it offers. The SNP array was also used and used successfully, but the hybridization problems that existed in the SNP array has made NGS a superior platform. So now let's come on to PGT-SR, that is the PGT that is used for structural rearrangements in the chromosomes. It is employed to identify embryo chromosomal structural abnormality, including reciprocal translocations, Robertsonian translocations, inversions, complex translocation, pathogenic microdeletions, microduplications, etc. So any copy number variations except aneuploidies for which we have a separate testing, we can use the chromosomal structural rearrangement, especially when the couple is a carrier of the same. The incidence of chromosomal balance translocation in the population is approximately 0.25%. Traditionally, FISH technology and STR haplotypes were used for the same. And this haplotyping technology had a high rate of false positive as well. Significant progress has been made in the development of new PGT technologies, and now there was a development further of a combined micro dissection techniques near the translocation points by NGS. This method accurately detected SNP as well. Although the NGS scenario-based techniques have been introduced to PGT-SR, these approaches could not identify a euploid carrier embryo or detect the breakpoints of structural problems in a balanced embryo. So the balanced translocations are still being missed, but we are getting the pathogenic unbalanced translocation, and thus the technique is quite useful. So before PGT-SR treatment, 83% of 592 pregnancy were miscarriages, 13 had induced abortion, but after PGT-SR, 118 clinical pregnancy occurred and 85% were normal births. So this really just shows the success of this technology and the ease it gives to the couples for a successful outcome. Although not all miscarriages or birth defects were avoided, of course, because we are still using an ART, PGT-SR show an apparent improvement in pregnancies. Now let's, I have very less time left, but I'll just give a glimpse of the newer technologies now that are present. We have a novel PGT technology known as PGT Plus, which is used as a comprehensive PGT method. Currently, genetic conditions are detected separately by PGT process by different technical platforms. Compared with the traditional detections of PGT A, SR, and M, a cost-effective, comprehensive, and universal platform for embryo testing with different genetic disorders coined as PGT Plus is worth developing and now is being tested and being validated. From a perspective of technology, a comprehensive PGT can be developed to detect monogenic disorders, aneuploidies, as well as chromosomal rearrangements together in the same embryo as a single test. The first combined PGT Plus was done in 2019, and since then it is now being validated, and hopefully we will see it more again soon. So Pardo et al. Also demonstrated a feasible method for autosomal dominant polycystic kidney disease through combined PGT approaches, where you can test for aneuploidies, monogenic disorders, that is autosomal dominant polycystic kidneys together, and give them a chance for a more successful, like a more optimal pregnancy outcome. One PGT based on reduced representation genome sequencing. This is a novel method, and it's a method for automated haplotyping and copy number assessment of embryos. So basically, this method, that is the STR-PCR, it results in an automated system where the aneuploidies, the structural rearrangement, as well as the monogenic disorders are tested together. So the reduced representation genome sequencing sequences all the points of the genome together and looks for any abnormality that might exist to the same. Compared to the validation methods, the PGT results shows 100% concordance in 10 samples. That means it's a great way forward. And then finally, we have non-invasive embryo viability testing or non-invasive PGT. It's also known as no PGT using traditional trophoectoderm biopsy techniques was implemented worldwide and has been of benefit to thousands of families. However, micromanipulation techniques require specialized equipment and highly skilled embryos. Additionally, embryo biopsy is invasive and people may concern it to be potential problem to the embryo development. Accordingly, a non-invasive sampling approach has emerged, and this non-invasive sampling approach is known as non-invasive embryo viability testing or no invasive PGT. Finally, to end my talk, the last of the novel PGT techniques that we can talk about is the pre-implantation genetic testing for polygenic disorders, that is PGTP. The PGTP technology focuses on Mendelian genetic disorders that reflect an inheritance pattern of more than one gene. According to WHO, we have seen that except COVID-19, 7 of the 10 leading causes of death globally were chronic non-communicable diseases, including cancers, cardiovascular disease, diabetes, etc. All of these diseases are not monogenic but polygenic. Thus, if we can actually go and find out that which genetic components affect these polygenic disorders, we can test those in the embryos and eliminate it and offer what is known as PGTP. As the name suggests, PGTP involves a biopsy of each embryo and ranks the embryos beautifully in the list in the order of their polygenic risk score, in the order of which embryo is more likely to get diabetes, which embryo is less likely to get cancer, so that an embryo selection can be done. A lot of debate surrounds this concept of a designer baby, but then are all of us not trying to be designer after all? Thank you so much for this opportunity. I hope my talk was useful. Thank you.
Dr. Geeta is there. Dr. Kushada, I think, may have left. But thank you, Veronica, for a very comprehensive talk on PGT. I think a lot of doubts have been cleared there. I don't see any questions, but we'll move on to our next session. So thank you once again for that. If there are any questions, we'll address that. Yeah. Thank you so much. Shruti, you want to take over from here?
Yes, ma'am. Let's move on to our next session.
So we go ahead with thank you.
Sorry to disturb, guys. I need to leave you the next half an hour. I'm Kailash Nakade. I'm talking on the last topic. I need to catch a flight in half an hour.
Right.
Otherwise, I won't be able to do my presentation.
Okay.
Is it okay if I go next?
Sure, no problem.
I think.
Thank you so much for joining. I know you've.
I'm really sorry. I just finished my theater and I'm coming to India. So I need to go to airport and I need to leave within next half an hour.
No issues. No issues.
That's okay.
Absolutely. So can we have his CV slide? Is Sarita here? Because she's joining me in sharing this session. But not an issue, Dr. Kailash. We will take your talk. Vandana, I hope that's okay with you and the panelists, yeah? Yeah. Just go ahead with the... Hello, Shreya, can you just put on the... Can you show the slide of Dr. Kailash Nakhade, please? Yeah. Sarita is, I think, not. Yeah. So it's our it's a privilege and honor to introduce Dr. Kailash Nakhade, who has joined all the way from Milton Keynes Hospital. He's a consultant gynecologist there. Thank you very much and really appreciate you sparing your valuable time for us. His special interests are gynae oncology, minimal invasive surgery, robotic surgery, and he's done the first robotic hysterectomy using the Versius in UK and Europe. He's the member of ICOG and, of course, BSG and BARGS, that is the Irish Society of Robotic Surgery, and also of the British Society of Colposcopy and Cervical Pathology. He's going to talk to us about another aspect of genetics, about familial hereditary cancers. Over to you, Dr. Nakhade, for your presentation. Shreya, if you can stop sharing, then he can start sharing as well.
Yeah, thank you very much, Sita. So,
Shreya, can you please stop sharing? Yeah. Kailash, you're muted. Hello? Hello, you're muted, Dr. Kailash.
Shreya, if
okay, sorry, I was muted. Can you hear me now?
Yeah, yes, absolutely.
Yeah, and do you see my screen at all or no?
Not yet, no.
Not yet. Okay, so I have gone in to share the screen, but do you need to allow me to share the screen or?
You are a co-host. Shreya,
can
you see the share screen button below on the icon? Shreya, have you made Dr. Kailash Nakhade the co-host? Let me just double check.
Ma'am, he's already co-host.
Yeah. You should be able to see
So
icon sharing.
can you see it now or?
No.
No? Okay. What do I'm going to the host tools and share the screen is already allowed for all participants to share the screen. So
is your PPT there on your desktop, on the desk
no,
screen?
laptop. I'm talking from my laptop.
Yeah, so in the laptop screen on the sort of screen.
Yeah, it's open.
Yeah, it's open, right? So you should be able to, if you stop sharing and try sharing again.
Okay, let me try that again. Okay. So host tools, and so I've stopped sharing now. And if I start sharing again,
No, we can't see it. There's a green button at the bottom called share. If you click,
okay, I'll use that one then. Okay.
Then it will show all your icons on your screen.
Yeah.
And then
So
tap.
host tools, share screen, and yeah, share. Yeah, is that? Are you okay to see it now?
Yes, sir. Yeah, we are beginning to
You
see.
are
Yes.
okay. Okay, thank you.
Yeah.
And I'll just
Make
carry
it-
on.
Make it full screen now, then that will be great.
Yes. Okay. Yeah.
Yeah, that's great. Thank you so much. Okay.
Okay. So first of all, thank you very much for inviting me, and thank you, Sarita. And it looks like very interesting seminar and webinar as well. As I said, I work at Milton Keynes Hospital. I'm a gynae oncology unit lead there and colposcopy lead as well. So I do see patients with some hereditary gynecological cancers, and this is one field that's is becoming more and more important for us, and not only for gynecologists, but gynecologists, general gynecologists, geneticists, and people in general, people in preventive medicine as well, because a lot of these genetically inherited cancers can be prevented. And if someone like Angelina Jolie, you might have read in the news that it was quite a big news, at least here in Europe and America, when she had her double mastectomy and also her bilateral salpingo-oophorectomy because she had a BRCA gene. And if people or celebrities like this have the surgery, then the public, more people also get more interested. Yeah, similar stories with Joe Cunningham. So as we know, the cancer is on rise due to various factors, but we are all at a risk of having cancer at some point in our life. And about 1 in 3 people will develop cancer at some point in their life. Most likely, these are like breast cancer, more common, but ovarian cancer as well. It's about 1.5% lifetime risk, and this is for the whole population. But not all these cancers are hereditary. About 85% they are sporadic. What sporadic means that they arise from a mutation in the genes that is not been transmitted by the family members. So it's a new mutation. Out of these, about 5 to 10% are hereditary. That means the faulty gene is present in the family members, okay, parents. About 10% is familial. So the difference between familial and hereditary is familial means there is no specific gene, but they have got strong family history of similar cancers. So it is important to identify this 10 to 15% of the subset of people who have cancers, because we can do something about it. And this is what I'm going to talk about it. My talk is mainly meant for a gynecologist, a general gynecologist, gynecologist. Some of you may be practicing. I'm not a geneticist, so this is a very vast topic. If you have got any questions at the end, I may be able to answer, not all of them, if they are very technical and particular. So why do we want to know that the genetic cancer, which are the genetic cancers? Because as I said, we can do something about it, do preventative strategies, better treatment, maybe early diagnosis. We know that in any cancer, if it is early diagnosis, the prognosis is better. And this is just a list of some genetic cancers, the common ones. So for us, what we are interested really is the breast and ovarian cancers, and endometrial cancer with the Lynch syndrome. But these are some other rare types like Cohen syndrome and Peutz syndrome, where you can get some gynecological cancers as well. But it is a vast field about hereditary cancers. Okay, so out of the ovarian cancers, about 20 to 25% cancers can have genetic cause, and about 14% or 15% of endometrial cancers can have genetic cause. And so it is very important to have the genetic testing for these type of people, or to identify these people. And the most important part of this is keeping patient at the center and counseling. And the counseling can come at every point, every contact with the patient. Could it be with a primary care, like a GPs, secondary care doctors, patient who are actually treating, and specialist counseling can be done by people trained in genetics, such as we got in UK specialist genetic centers and specialist genetic counselors, and also genetic consultants in genetics. So that can be at tertiary level. So counseling, not only about what condition they have, but what are the implications, how they can prevent it. If they have already got cancer, what are the implications for their treatment? And what are the implications for other family members? Okay, and as we work in gynecology, there are implications, things about treatment options have implications for menopause, HRT, fertility. So all these things need to be really looked at on an individual basis. So going a little bit in the basics. So what is a hereditary cancer? So we need to understand basics like cell. We know that the cell are the building blocks of the body, and every cell contains DNA, which is a hereditary material, and the sections of the DNA are called genes. And what we look at genes, and many genes are in chromosomes. So we have got 23 pairs of chromosomes, one each coming from our father and mother. So the genes have some mutations in their DNA, and these are called variants, okay? And when we use the term variants, or for us, it's a mutation, it's a change, and that is responsible for formation of these cancers and many other non-cancerous conditions as well. So we should thank this lady who really started all this, is Mary Claire King. She discovered the BRCA one gene, and look, that can cause hereditary breast cancer, as we know. We'll talk about that in a bit of more detail later. And nowadays, there is when you request genetic tests, it's not only that you can request a single genetic test, but it's available now to have a panel of genetic tests. And it is just impossible for us to remember all the names. And of course, we have to take advice from our genetic specialist consultants, but you can request an array of testing is available, and the number is just increasing as we go. So when we do the genetic testing, you'll come across these terms, sometimes what is called as what is a somatic mutation and what is a germline mutation. So somatic mutations are the changes that happen in the tumor cells. Okay, so as you can see from here, is that the cells are normal to begin with, And due to whatever factors, environmental factors, viruses, whatever, there is a genetic mutation that causes cell damage. And further mutations keep on happening. And after quite a few mutations like this, finally cancer starts. So sporadic cancers happen that way. And if we check the gene testing for these tumors, so for somatic mutations, we have to check the tumor tissue itself. And that is how we will find that is. Whereas germline mutations are with hereditary cancers, but there is a faulty gene already present in that person. Okay, so which has been passed on from the parents. So there is already a faulty gene, already a first mutation there happening, and if further mutations happen, and then so cancer cells develop. So there are different types of testing, as you say, for genetic tests. So what do we do? So germline, as we said, our hereditary testing, it is to identify people who are at an increased risk of cancer. So this is like testing for BRCA or BRCA2 genes in patients who haven't got cancer, who have got a strong family history of cancers, like breast cancer, ovarian cancer, or who are related to someone who is now found to have a BRCA genes. So that is called hereditary testing, okay? And what it does, basically, it allows for early detection, prevention, and treatment. So we will talk about that, how that happens in ovarian as well as endometrial cancers. So this is hereditary testing. So this is done for patients who haven't yet got cancers, but have got history, strong family histories of cancer. So there's no relative who has got these faulty genes or variants, as they called. And depending upon there are different genes, there are different risks of different cancers. And also the same cancer risk is also different in different genes, which we will also talk about a bit later. Whereas tumor testing is now coming up more in vogue, and certainly it's more in America, certainly in UK, last 5 years, I think it is catching up. I do not know about India, what the situation is, what happens, but it is happening more and more again. And this is to test for the somatic mutation, as we talked. So, and why this is important is that it will tell us if there is a faulty gene or a particular specific gene mutation. Knowing that, then we can determine what is the best treatment available. Such as, for an example, we know that patients with BRCA genes, BRC and BRCA2 genes, and they get ovarian cancer. So we check those for in the tumor. They are more likely to respond to certain type of drugs, such as these PARP inhibitors. Okay, so it also helps us, and when I say us, it's mainly the medical oncology consultants, to have targeted therapy for the cancers, such as which type of chemotherapy might work better, as you say. Can they be better off with an immunotherapy? Is there a better response for recurrence disease? Okay, so this is the medical future where we will be able to offer a personalized approach for each individual patient with cancer. So I'm sure in future, this type of testing is just going to go on increase, and it is happening in cancer patients, but it will happen in even non-cancer kind of conditions as well, such as heart disease and other things. Okay, so this is again just a table really which shows what is the differences between germline and tumor testing, which we talked. So sample taken for the germline testing is usually blood or saliva, whereas tumor testing is the tumor biopsy. It could be the final surgical specimen biopsy, or it could be just a diagnostic biopsy, or in patients with ovarian cancer, sometimes it could be just the ascitic fluid and get some cells from there. But it may be difficult that way. They need a good sample. So the purpose of germ cell testing is actually to learn the risk of the cancer. Sorry, let's go back to the slide. Learn the risk and what are the implications for a patient and family, whereas tumor testing is more about the best treatment options. So who can offer germline testing? So it can be offered by anybody, really, whoever comes in contact with the patient. So general practitioners, here general practitioners, all the patients are registered in NHS with general practitioners, so they have a role. I know in India, we don't have a specific GP for every person, but so more like for an organized kind of testing, but certainly secondary care physicians such as us, gynecologists, or anybody or medical oncologist who can request a germline testing, or even a medical oncologist treating anyone who thinks that person is at a higher risk, fits in the criteria, can request a germline testing. Whereas tumor testing is usually done by an oncologist after the surgery. Or it's asked by an gynecologist specialist, MDT. Okay, so what are the results? So when we do the testing, these are some of the kind of results that come, and what do they mean? So if the result is positive, that means definitely the mutation is identified. The negative result is different if the mutation has been previously been identified but it's negative. So they can be true negative, or it can be mutation unknown. So for practical purposes, negative result is taken as negative. That's not there. But in about 50% of patients, or 40 to 50% maybe, you get this result called variant of unknown significance. And this is a difficult area to treat because you may have a strong family history, but if you say the BRCA genes is unknown significance. So I was doing a bit of search on this one, and most of the guidelines suggest that if it is a variant of unknown significance, we still think that they treat it as negative, but with a chance that things can be revisited later, or if the family history changes or there are other things come forth, then they can have a repeat testing done at some point. But that is an area where I think we need to probably get advice from specialist genetic consultants. Okay, and this is just says what is positive. So positive result in a germline testing does not mean that the patient has got cancer. It is very important. What it means as the patient is at a higher risk of developing cancer. So that is why they need to have this opportunity, a discussion about early detection, prevention, what can we do, and then what type of gene it is as well. It depends on that. Okay, so again, so there are various genes with different risks of genetic cancers. For us, really, as a gynecologist, most of these are high risk of breast cancer as well. But looking at ovarian cancer, the most of the common genes that we want to know is about BRCA genes, BRCA1, BRCA2, BRIP1. PLAB is slightly not that as high, but there are other genes, RAD51C, RAD51D, and even the Lynch syndrome genes defects, MLH1, MSH2, MSH6, and PMS2, they also increase the risk of ovarian cancer. Okay, so we need to know that, but they also increase the risk of endometrial cancer. But in addition to these gynecological cancers, these patients have increased risk of other cancers, and that may have, like in Lynch syndrome, there's quite a high risk of even colon cancer. Whereas PLAB, there's pancreatic cancer, and BRCA, not one, but mainly two. There's quite a high risk. When I was doing a bit of search for this talk, I was a bit surprised. There's quite high risk of prostate cancer in many of the BRCA2 genes. So, and the breast cancer, of course, you are all aware that they're called breast cancer genes. So it all started with the breast cancer. They've got quite a high risk. So talking about ovarian cancer, so as I said, about 24-25% patients are has a history of hereditary cancers and maybe gene. And this is probably the similar side, and the most common genes actually we come across is BRCA1 and 2 genes that we need to deal with patients. These are actually tumor suppressor genes which are involved into the repair of the tumor DNA. And then if there is a defective BRCA1 or BRCA2, that's when the DNA repair does not happen, and then that leads to cancer. So about 5% of breast cancer cases and about 12% of ovarian cancer cases are actually may have more genetic things as well. And these are just the similar slides actually. So these are the key genetic mutations that we need to talk about, BRCA1 2 genes. So with the BRCA1 mutation, the lifetime risk of developing ovarian cancer is quoted from about 39 to 46 or 40 to 50% really is the risk, and that's the lifetime risk. And the risk increases with the age of the patient, okay? With the BRCA2 gene, the risk is about 10 to 20%. So we quote about 25-30% risk, a lifetime risk with the BRCA2 gene. And there are different age differences, which we'll talk about when the risk of BRCA1 starts a bit early and BRCA2 genes risk starts a little bit later. The other factors are the RAD51C, RAD51D, and they have got a moderate risk, and that risk is about 10%, I think, or less than 10%. But also for ovarian cancer, we shouldn't forget even Lynch syndrome genes also increase the risk of ovarian cancer, which I already said. We talked about this really, okay. So this is just a thing again. So what is the risk? Breast cancer risk is even higher. So with BRCA1, the breast cancer risk is about 50 to 85%, ovarian cancer 20, and also male breast cancer risk is about 6-7%, I think, with 1 or 2. Prostate cancer risk is high in BRCA2, pancreatic cancer mainly in BRCA2, and some melanomas as well. So they got implications for lots of other things. Okay, so we talked about that already, I think. And the inheritance of BRCA mutation is thought to be autosomal, and each child has a mutation carry a risk of 50% chance of inheriting from the parents. And when you say parent, we shouldn't forget it's both male and female can carry these, okay? It is more prevalent in specific populations such as Ashkenazi Jews. And yeah, so it's important that both male and female can carry BRCA genes and can be passed on. So this is another table, which is a bit thing which says different types of risk. For us, important really is that you can see BRCA1 ovarian cancer 40 to 60%, BRCA to 15-30, and then others are a bit smaller, but important thing is that they got other risk, breast, colon cancer in other things like STK11, which is Carter syndrome, I think, and other even gastric cancers, pancreatic cancer risk in ATM, which is, I not heard that before I started searching for this presentation, is about 30%. Okay, so I think we had talked about this. This is just a diagrammatic representation. So what can we do for these patients? So we do know now that they have got at an increased risk for development of these ovaries. So how do we monitor them? How do we counsel them? How do you prevent ovarian cancer in them? What is the strategies to do that? So we'll talk about a little bit about that. So is there a screening for these patients in ovarian cancer? Well, as you know, there is no nationally or internationally accepted screening for ovarian cancer, as it is for cervical cancer with smears and other things. However, there are lots of publications and guidance about screening for patients who are at a higher risk of developing ovarian cancer. Although even here, there is not much consensus. So patients with BRCA1 and BRCA2 genes can be screened by an ultrasound scan, a transvaginal ultrasound scan. Again, it is no consensus how frequently we should do it. Some of the, as I will see from next slide, some European medical oncology guidance and suggest that maybe every 6 monthly ultrasound scan, whereas a recent NICE guidance has come for this in the UK. As you know, NICE is a National Institute of Clinical Excellence, and NICE gives guidance specifically for patients in NHS and cost effectiveness, and they don't even mention ultrasound scan. What there is some agreement on is that we can do a CA125 every 4 to 6 monthly, and there are specific algorithms which the lab should advise. I don't think it will be available everywhere, that can suggest if there's a increasing CA125s, then whether we should do further scans or offer surgery or laparoscopy or whatever it is. But this is an area where there may be a lot of research going, but certainly there is no specific guidance. I think the ICOG in the US states that you can do CA125 and ultrasound every 6 months. So, okay. So what are the, if there is no screening, then at least can you prevent these people having ovarian cancer? And when we talk about ovarian cancer, it's mainly epithelial ovarian cancer, because this really doesn't apply to other rarer tumor types, such as mucinous tumors or germ cell tumors and things like that. Okay, so what we're talking about is mainly, when we say ovarian cancer here, is mainly epithelial ovarian cancer. So it is very important to actually find out what is the exact risk of that person developing ovarian cancer. And there are lots of genetic formulations, calculations which geneticists use. I wouldn't bother you with all that. And they can tell us what percentage. Is it 4%, 5%, 10%, 20% risk of this person developing cancer, and what age? Once we know that, then we can talk to them about what can we do prevent ovarian cancer in them. The other thing about the screening, I just want to talk, it is very important to know that screening doesn't prevent cancer, okay? Screening will only identify cancer at an earlier stage. Okay, the only way to prevent cancer in patients with ovarian cancer is to remove their ovaries. Okay, and that way also, it is not going to prevent all 100% risk of cancer. So these are the surgical strategies as a gynecologist we might do. So the most common recently researched and consensus is bilateral salpingo-oophorectomy. So risk-reducing bilateral salpingo-oophorectomy in these patients. And there are quite a few research studies on that, which suggest that in BRCA1 and 2 patients, there's about 94% risk reduction in ovarian cancer. Why it is not 100%? Because these patients can still develop peritoneal cancer, primary peritoneal cancer, which can act as ovarian cancer. It's like ovarian cancer. Okay. Then, and 68% overall reduction in population if you do this randomly. Important thing too about, we'll talk more about bilateral salpingo-oophorectomy, but are there any things? And so we cannot do bilateral salpingo-oophorectomy in any patients because they may be young, they have not finished childbearing, so at what stage we should do it, how we should do it, and what counseling they need before and after, and how to manage their other symptoms. We'll talk about that in next few slides. But can we just do a salpingectomy? And there is some evidence that most of the epithelial ovarian cancers, at least the high-grade ones, actually start as a tubal cancer. And if you do just a salpingectomy, opportunistic salpingectomy even, then that reduces up to 50% reduction risk of ovarian cancer. So if you're doing, and it's now quite well established in the UK, at least most of the centers, I'm sure probably in India you're doing the same thing. If you're doing a hysterectomy for anyone who has got benign cause for a hysterectomy, fibroids, menorrhagia, etc., but you're keeping the ovaries because they're young, then you should remove the tubes at the same time. So you can do an opportunistic salpingectomy. And there is some evidence of research that it does reduce risk of ovarian cancer in future. I did come across some mention about that femoral end must be removed completely, because even if a bit of femoral end is left and you've not done a proper salpingectomy completely, then there is still a risk of developing ovarian cancer. Is there a role for opportunistic salpingectomy? Means do salpingectomy if they're having any abdominal surgery, such as appendicectomy or bowel surgery or anything. Not much research in this area. And this is only if they are finished childbearing, okay? But that is something we may hear much more in future. Our practice might think. What about just doing tubal ligation? And also there is evidence that there is about 10% reduction in the risk of ovarian cancer just with tubal ligation. So there is also thinking about then if salpingectomy reduces the risk of ovarian cancer up to 50%, then shall we just do salpingectomy as part of tubal sterilization rather than just doing the Filshie clips as we do in the UK, or you do the Yoon bands? I remember doing them in India when I was there. So all those things. So those are lots of things to think about it. But I know the trend in America is going, and even in our hospital, and we have started doing more of a salpingectomy. But you have to think about the patient. Then you cannot offer them the tubal recanalization again if they want to have. So that discussion with the patient earlier on is important. So these are some of the recent recommendations about prophylactic bilateral salpingoophorectomy. So if the patient has got a BRCA1 gene, then it should not be done less than 35 years. If it is BRCA2 gene, then recommendations after 40 years. For others, is not earlier than 45 years. And again, if they've got a Lynch syndrome, not earlier than 35 years, because the risk of development of cancer before that is much less, okay?
Kailash, I'm requesting you if you can just wind
at
up
the same
in...
time. Sorry?
Sorry, Kailash, I'm requesting you if you can wind up in 5 minutes.
Okay, 5 minutes. Yeah, definitely. Sure. Okay. So you shouldn't do a hysterectomy unless there is any other pathology. Minimal access route should be used. It should do ultrasound and CA125 before the procedure to rule out for occult cancers. And we should do peritoneal washings at the time. And they can have HRT up to the age of 50 years or 51 years, the normal age of menopause. This is similar recommendations again from the European Society. And as I said, you have to find the risk of the stratification and then offer the treatment. So usually treatment is offered if it is more than 4 or 5% risk. And I'll go through that similar things. So this is a nice guidance if anybody wants to see, and it tells you which type of patients needs to be referred for testing. Now they say any person with even a first degree or even a second degree relative or of cancer, or if they are particular origin like Ashkenazi. So a couple of slides of Lynch syndrome. So this is autosomal dominant condition. It increases the risk of endometrial cancer, also colon cancer. And these are the genes for Lynch syndrome, MLH1, MSH2, MSH6, and it increases risk of many other cancers as well. So they need to be referred accordingly to colonoscopies and things. Okay, I wouldn't go into the basics of that. And there are different guidelines or different ways of diagnosing Lynch syndrome. But for us to know that Lynch syndrome increases risk of endometrial cancer, and we can offer them screening, again, not proven, but most proven is endometrial biopsy every 1 or 2 years from the age of 30 to 35. no data supporting we should do ovarian cancer screening and Lynch syndrome, and we need to offer them prophylactic hysterectomy as a treatment. We can conserve the ovaries if the mutation is only PMSS2. Counseling is very important. Fertility issues, again, very important. They can be referred for fertility treatments such as egg freezing, pre-implantation genetic diagnosis, etc. There is some research about progesterone, Mirena, not proven whether they can be used for these patients to prevent cancer. This is similar guidance for BGCS. So key takeaway is we need to know about the genes, and we have got strategies to prevent the risk. However, careful counseling is very important. Thank you very much.
Yeah, thank you, Kailash. That was a wonderful talk, and thank you for giving us such a clear idea of how to manage this very difficult situation of familial cancers. You know, today we have patients who are coming and who are with even one relative and asking us, are we at risk? Relatives are coming, etc. So I hope we didn't delay you to your flight.
No, that's fine. I have to leave. I'm still in the hospital, so I have to go home and leave within an hour.
Okay.
Not a problem at all. Thank you very much,
Thank you
Sarita.
so much, and it was a
the team.
pleasure having you, and look forward to seeing you now in India.
Thank you so much.
Thank you. Thank you. Bye-bye. Bye. Thank you.
So we move on to the much awaited panel. We are running very late, but thank you all delegates for staying back. And Shruti, if we can quickly go on to the panel and introduce the moderator and panelists. Thank you for bearing with us. Thank you.
So moving on to our next very interesting session, that is the case scenario with genetics and fetal medicine. Shreya, can we have CV slides, please? Moderator for the session is Dr. Vanna Bansal, ma'am. Previous slides, please.
To go back, yeah.
More. More. Yes, thank you. Ma'am is a wonderful moderator, and also she is a obstetrician with super specialization in fetal medicine and interventions, and she is the first postdoctoral fellow of National Board in India qualified in high-risk pregnancy and perinatology. She has over 28 years of experience in obs and gynae, including 23 years in fetal medicine. She is MUHS approved faculty for fellowship program in fetal medicine and also ICOG course coordinator. She is chairperson of fetal medicine committee, national coordinator imaging science committee, member of management committee MOGS, and vice president Society of Fetal Medicine Mumbai chapter. Ma'am has received NA Purandare Best Paper Award and many more awards, and she has over 50 publications, including 30 papers in national and international journals. Please welcome, ma'am. Next, I would like to invite our panelists for the session, Dr. Jaya Chawla, ma'am. Ma'am is Professor, Department of Obs Gynae at RML Hospital. She is also Joint Secretary, Society of Fetal Medicine, Delhi chapter. She is executive member, Genetics and Fetal Medicine Committee.
My dear Shruti, we can always proceed to the session.
Yes, ma'am.
Let's cut this short.
Okay, so my next panelist is, next slide, please. Dr. Sangeeta Yadav. She is professor at Department of Maternal and Reproductive Health, SGPGI, Lucknow. Next slide, please. Dr. Sakshi Yadav. She is working as clinical geneticist at Care Diagnostic Center, Zirakpur. Next slide, please. Dr. Ashita Srivastav. She is consultant fetal medicine at Nishant Hospital, Patna. Next slide, please. Dr. Sumona Haq. She is consultant in charge of fetal medicine at Neotia Bhagirathi Newtown Hospital, Kolkata. Next slide, please. Dr. Preeti Dubey. She is the founder secretary of SFM, and she's running Odisha Fetal Medicine Center. Next slide, please. And Dr. Megha Sharma. She is the director of Nidan Heart and Fetal Medicine Center at Kota. Welcome everybody on board. And ma'am, can we please start?
Thank you, Shruti, for introduction of all this panelists. So can you, yes, I will share my slides first.
Are my slides visible?
Yes, ma'am.
So I would want to thank Dr. Sita Pal for bringing us all together for this master class in genetics, and it is a huge success because it was more than 100 people who joined, and there were many more who wanted to join in. So we've discussed a lot of lectures. Now we will take them through some cases, and for this we have a excellent panel of maternal fetal medicine specialists as well as fetal medicine specialists and geneticists with us. So what cases I'm going to take you through, we will all go together through all of them. So for each of the case, let us have one maternal fetal medicine and one fetal medicine and a geneticist for each of these cases. So just a background, yes, universal screening is being done for all our cases, both for aneuploidies and for anomalies. We have our first trimester screening, and when we combine it with nasal bone ductus TR, our detection rate increases to 95%. And we also look at structural abnormalities at 11 to 13 weeks. If we miss the bus in the first trimester, we still have a quadruple test, and now with the NIPS, which is available. So when we have a screen which is done, whether there's a structural abnormality or a screen which is positive, we have these three tests which are available: the chorionic villus sampling, the amniocentesis, and the cord blood sampling. But our cases now are going to be, yes, we've done a test. What has to be sent for it? Do we send a chromosomal menu for this, and which part of the chromosomal menu, or whether we send a single gene menu? For basic obstetrician, let us keep it little simple as to what test do we want to do. And with that, we will have some cases to take us forward. And for our first case, let's have Dr. Jaya and Preeti with us, and Sakshi can add on whenever there's something on genetics which is controversial, she can add on to that. So first case we are taking is, how does traditional karyotype help us when we have an ultrasound diagnosis, which is very typical of a chromosomal abnormality? So, Dr. Jaya, we have this patient who has been sent to us for an increased NT and a hydrocephalus in the first trimester. So, Dr. Jaya, can you kind of see the images and say what all do we want to look at when we have an increased NT in this case?
Ma'am, here, as we have seen in the second section, the axial plane, we see that there's a typical picture of an alobar holoprosencephaly. So we have a typical genetic association in mind when we are looking at it. But just for the sake of completing the picture, had it not been this, a raised NT can be associated with a spectrum of abnormalities. So these can be the most common one that we encounter in clinical practice is the cardiac abnormalities. We can also have a diaphragmatic hernia or an omphalocele sitting there. We can also have a straightforward big kidneys, typical Meckel-Gruber kind of a picture present over there. We can also encounter a megacystis or a skeletal dysplasia. We can also see that something like skeletal is not present right in the first trimester, but may be found on the follow-up. Then we can also have a possibility of genetic anemias, such as Fanconi's anemia, Diamond-Blackfan anemia kind of things. Also, whenever there's a raised NT, we have to look at it from the perspective of whether it is persisting in the second trimester or not. And if it is persisting in the second trimester, then our differential should also include genetic fetal infections. Also, there can be possibility of syndromes such as the Noonans or the Smith-Lemli-Opitz, etc. Then there is also a possibility, and we have to counsel regarding the possibility of neurodevelopmental delay in about 2 to 3% of these cases. However, the first thing that has to come to the mind with the raised NT is that the percentile is important. Not every case of raised NT is going to have all of the spectrum of disorders. And we have to counsel that at less than 95th centile, more than 97% of babies are actually not going to have any major abnormalities. And between 95 and 99 percentile, still a possibility of a good outcome is to the tune of 93%. Also with a raised NT, and invasive testing is called for.
So one point that you brought about is when there's an NT, you look for rest of the baby for any structural abnormalities, for any cardiac abnormalities. And if you see something like here, you see a holoprosencephaly, does it help us in deciding which test we are going to send for?
Definitely, ma'am. Definitely. The first thing being this, that this is not compatible with life. An alobar holoprosencephaly, we have to terminate. So the first thing is that maybe an amnio is not as necessary here, and we can test the abortus also. That is one possibility which we may not have in other cases. And the second is that a genetic testing, in general, with a major abnormality, we follow the pattern of a fish followed by a microarray. So here, if the fish is very likely to give us a diagnosis, we may not really have to offer a more detailed genetic analysis.
So Preeti, just tell me, we are going to terminate this pregnancy. Do we offer any test to her, or can we, as what Dr. Jaya said, that we can terminate and then we send the products for testing, or it is something which is not, it is lethal, we just leave it and don't do anything for it? Preeti? I think we missed on Preeti. She was there.
Dr. Preeti, I think you're muted.
Preeti, you're muted. Preeti, can you unmute yourself? Can the production team look into it? Why she has to be made a panelist, maybe?
She's unmuted now. Preeti?
Preeti, now unmute yourself.
Hello, can you hear
Yes,
me?
yes, correct.
Yeah, sorry, ma'am. Sorry for the inconvenience. Actually, when we see an increased NT and with associated with holoprosencephaly, as we know that holoprosencephaly is a lethal anomaly, but it is directly related with trisomy 13. Isolated anomaly that we can see in the first trimester and we can diagnose a syndrome. Holoprosencephaly is one of them. So we have to rule out trisomy 13. And for that, as it is a lethal anomaly, better not to put the needle in, and rather than we can do the fetal sampling for karyotyping.
So both of you have said that maybe you can do a karyotype after the fetus is aborted. So here, in addition, there was tricuspid regurgitation. As you said, cardiac anomalies are more common. So if you see an increase NT, do you ask for a screening test? And if so, which screening test?
In increased NT, first we have to see for other marker like nasal, bone, tricuspid regurgitation and ductus venosus, like other aneuploidy marker. Beside this, we have to structurally evaluate the entire fetus from top to bottom. If any associated with anomalies or if aneuploidy markers are there, then we need to investigate her. If that is not there, then normally we can send NIPT for that. If everything is normal except increased NT.
I guess the quantum of the NT would also be important here in determining the future course of action. Something which is more than 99 centile or straightforward a cystic hygroma, then our choices might be different from something which is, bordering, I'd say, between 95 to 99.
If structurally, if the baby is normal, if there is no other association, then only NIPT we can do. After evaluating the baby completely.
I think I would beg to differ, because with an increased NT, which is more than 95th centile, NIPT will only help us in Down syndrome and not for rest of the things. So maybe even if all the structures are normal, I might still do a sampling to see. Yes, as what Dr. Jaya said, that 95% of them can be normal if there is no other structural abnormality, but testing needs to be done for all of them. So as you all said that we can do a test in the sample after the baby is terminated. So what problems can happen while we are doing this sampling, and what test has to be sent once the fetus is aborted? Anyone?
As most likely we are suspecting trisomy 21, we can do karyotyping for the baby. And then we can store the DNA. And if we don't get anything in the karyotyping, then we can send for chromosomal microarray.
I think I would opt for a microarray on the abortus or the POCs straight away, because this is a dead tissue that I'm getting out of the abortus. So there is no potential for me to, culture it or maybe have the cells multiplied. So the best option here would be a high resolution or at least a medium resolution microarray.
So
I
the
mean,
rate
that's
of
my opinion.
culture failure is very high in abortus. So that is what needs to be understood when you're asking a patient to abort and then testing it. So then a microarray might be a better test to do. But maybe Sakshi, you can help me in deciding. For my patient, we did an amniocentesis CVS at this time, and we sent it for a fish first. So do you also do the same thing, that you first do a fish to find out whether it is chromosomal or whether we need to look at segmental disorders?
Yes,
Like
ma'am.
it was very typical of trisomy 30.
So
So,
yes, ma'am. Mostly when we are very sure कि भाई it is likely to be trisomy 21 or trisomy 13, because in that case we do a fish, we can save our sample, and depending on the result of the fish, we can then process for further testing. For example, if fish is positive for trisomy 21 or trisomy 13 in this case, we can do a karyotype to know what type of trisomy specifically is this fitting into it. Because in this case, because in any of these cases, further management or further risk of recurrence will be different, whether it is normal or simple trisomy, or it is any balanced unbalanced translocation type of trisomy.
yes, so my geneticists are always up and above when I tell them I want a fish report, and then we decide whether we do a karyotype or a microarray, because you can do a simpler test and get away with this if it is something like this. So add on to this, Sakshi, if I had done a microarray, would I have been able to pick up this unbalanced translocation in a microarray?
No, ma'am. In microarray will only tell you about the copy number change. So it will only predict whether it is trisomy 13. It will only tell you trisomy 13. It won't tell you what type of trisomy 13. Type means it is free trisomy 13, means 3 separate chromosomes, or is there any translocation between the 2 chromosomes which is leading to the unbalanced trisomy.
So that is very important. And here, if we have done a CVS, the karyotype could have been done. And so we could see the balanced or unbalanced translocation. Had we terminated the pregnancy and done a microarray, we would have to do parents to see what is the cause for the trisomy 13. So somehow, somewhere, it may be helpful to do karyotype and not microarray in such condition. So the recurrence risk, if it is pure trisomy, is only about 1%. But if it is balanced translocation, the risk can be as high as 10 to 15 to as high as 100% in 21, as what Dr. Ratnapuri also said. So our learning point is genetic testing is extremely important, even if it is something which needs to be terminated. And so we need to, one, look at the rest of the baby for other abnormalities. And second is genetic testing is extremely important. So with this, let us go on to our next case. And for this, I have Dr. Sangeeta and Sumona with me. So, Dr. Sangeeta, are you there with me? She's a patient who's been sent to me at 11 weeks with an increased NT, which is more than 99 centils. Hugely increased with cystic hygroma. Nasal bone is present, but and there's no TR, and the ductus is absent. So there is agenesis of ductus. There's some amount of pleural effusion, some edema around the baby. So what are our differentials in this case? As what Dr. Jaya said, there are a lot of disorders which can be there for increased NT. So what are we looking at, and how do we go further with this case? Dr.
So
Sangeeta?
here we are seeing the increased NT along with the absent ductus venosus. So now we are suspecting some genetic disorder, and we should go ahead with the invasive testing along with microarray, because karyotype might not pick microdeletions and microduplications which might be present in this baby, in this fetus. So we should go ahead with the invasive testing and microarray.
So, Dr. Sangeeta, I am little worried. This could also fit into something like Noonan syndrome. So, can we pick up Noonan on a microarray? So, how do we go further for this?
So I think we can go ahead with the fish, and we can do the targeted testing for Noonan in this case.
And a microarray also.
Yes, and a microarray also.
So sometimes it becomes very difficult to decide what test has to be sent. So we might want a geneticist to help us in deciding. In addition, it also had a single outflow tract also, which was seen. So what fish, QF-PCR, karyotype, microarray, Noonan panel, what do we send for?
So if we are suspecting something, like if we are suspecting Noonan, then we can do the targeted testing for Noonan. If it comes out to be normal, then we can go ahead with the microarray testing, because the DNA is stored in the lab. So we can do stepwise testing as per the clinical scenario.
So, but are we planning to terminate this pregnancy?
Yes, since we are seeing the single outflow tract, so the prognosis is poor. So definitely we should counsel that the prognosis is poor and we can go ahead with the termination. But before that, the testing should be offered so that it will guide us in future pregnancy management.
So, Sumona, you're with me. We did a test, as was said. We first sent for only a fish, and the fish showed us Turner. So now what test is to be sent? What recurrence risk is to be looked at? The fish is showing single sex chromosome, and the karyotype also showing 45X0.
So once so what I would have done is that I would have done the fish and I would have asked for a DNA storage. And then accordingly, after the reports come in 5 days, I would have accordingly planned the test, whether we should go for a karyotype or a microarray.
We've done that only. The fish was done only for a fish first, and when it came out as monosomy X, then we sent for again.
We would do a karyotype, ma'am, in this case, to
So
see
we've
what.
done a karyotype. It is 45X0. So what is the recurrence now, and what will you do for a next pregnancy? And
so, ma'am, this Turner syndrome, it is more or less, it is sporadic. So the recurrence rate is 1% or less than 1%. But still, we should test for the parents, so to see whether there is any mosaicism or not. And then we should plan accordingly in the next pregnancy.
So next pregnancy, we do screening, or do we do a diagnostic test now?
So, ma'am, depends upon the parental testing.
Mostly for monosomy X, the recurrence risk is going to be very less, as you said.
Very less.
So we would can plan a normal screening test for her. Anyone wants to add to this? Sakshi?
Yes, ma'am. Recurrence risk will be low, so we can just ask her for a routine aneuploidy screening.
So what we learned from all this is that fish is a very good test to start with. And once you've done a fish, then you can ask for a test depending on what comes on this. And here, because we were able to find that it was Turner and not Noonan and all those higher end tests, we could just do a normal karyotype and get away with this. Otherwise, if this was normal, then we would keep the DNA saved and work on the microarray and maybe later on. So in our own data, which we have published, the NT more than 95th centile was associated in 19% with aneuploidy. This is before we started doing microarray for all our cases. So it's a huge number which we have, which had Down syndrome in most of the cases. Now let's go on to our next case, and that those are cases which have got anomalies. So if you look at the data, all structural abnormalities are associated with genetic disorders. They may be higher in cardiac and CNS and maybe lesser in renal and GI. And there's a huge amount of overlap between all of them. That is why the prenatal testing is required in those with structural abnormality, and it also decides the morbidity and the mortality associated. So let us go on to our next case, and for this, we can have Dr. Megha and Dr. Ashita with us. And this was a case at 29-year-old primary gravida, 12.5 weeks. She was a DCDA twin to start with, and there was demise of one of the twin. And somebody sent for a dual marker. First, to start with this, can we do a dual marker in a twin with one fetus without cardiac activity? So, Dr. Megha, can we have your comment?
And basically, we should all understand that serum screening in twins with one fetal demise, it is not very sensitive because the markers, the PAPA values and the AFP values, they tend to increase after a fetal demise. So definitely, dual marker could have been avoided in this pregnancy, and we could have done the best method that we could have done would be a good NT-NB scan and to see whether the surviving twin is absolutely normal, the NT is fine, or there's no structural abnormalities. We could look for additional markers. But since we already have a test which shows a risk of 1:397, although I think it is around, it's an intermediate risk score, and if the parents are very much apprehensive for it, then we might counsel them about the sensitivities of the test, what should have been done, and then offer them testing if they won't.
Yes, so first is if there is a CRL without cardiac activity, it is not prudent to do a dual marker which has a biochemistry along with this. A good NT nasal bone ductus TR is the best thing that we should have done. But as you said, right, that once you have a report, then it becomes very difficult to go back and say ki this report is not useful, and the apprehension of the patients also. So can I do an NIPT then now?
No, ma'am. Absolutely for the same value, because NIPT will also depends upon the cell-free fetal DNA. And since we may have DNA of both the fetuses, even we may have a higher amount of DNA of the fetus which has already expired, and there are high chances that that fetus might be abnormal because it eventually could not survive. So even NIPT has less sensitivity in such twins cases. So if the parents want a test to be done and confirm whether it's fine or not, I think we should offer an invasive testing only, and no other testing should be allowed.
So we have done a CVS for her, and we sent for a fish and karyotype. Ashita, are we going to send fish karyotype, or do you send microarray for all your dual markers? And this is a false report of a dual marker.
Ma'am, actually, we first go with fish test. If it comes out to be normal and detailed structural analysis doesn't reveal anything, then KT may be an option. Otherwise, chromosomal microarray provides better diagnostic yield in approximately 8% of the cases.
Yes, but Megha, tell me, do you routinely for your dual marker send a microarray?
Ma'am, I follow the same scheme. We first do a fish. And then if it comes out to be the fish positive 21, 18, or 13, then I ask for a karyotype. Otherwise, I go for a microarray. I ask the lab to process microarray spontaneously if the fish is normal.
So here, this was a NT time. So it was not even a full structural scan which was done, but because it was only for a dual marker intermediate risk, and that also falsely done because there was a missed abortion along with that. So fish KT was normal. So we said, come back for an anomaly scan and we will see. So patient did not come back to us and came at 30 weeks to us. So maybe Megha, you can describe what happened to this baby.
Ma'am, I can see ventriculomegaly with 13 mm ventricles, and I think lyssencephaly with megacisterna magna, and an interhemispherical cyst which suggests corpus callosal agenesis. So, ma'am, if the patient, of course, the patient would have been like, it was since the test was done, why is it so? Because we did a confirmatory testing. But we should, during the time of testing also, we should counsel the patient that we are not testing the baby for everything. There are certain structural abnormalities that we cannot detect at 12 weeks. There are certain structural abnormalities which we cannot detect at 20 weeks. And the fish and the KT test that we are sending is only for the dual marker report that has come. We are not screening or testing the baby for absolutely all the abnormalities that can be present. Since these are neurological disorders, ventriculomegaly and ACC would have been picked up if we would have done an anomaly scan at around 19-20 weeks. But since the patient didn't turn up, it was lost. And at this point of time, we can just counsel the patient about further testing if they are willing to do at 30 weeks. As the DNA might have been saved, we could contact the lab because they might have the DNA, because they usually the labs store the DNA for at least 3 to 4 months, antenatal samples at least.
So here, did we miss the ACC in the first trimester?
Ma'am, we could have tried seeing, because corpus callosum, the structure may not be completely developed till 20 to 22 weeks. But yes, there are certain tests, there are certain markers. We can see the pericallosal arteries, and we could have we could have seen findings that could have suggested that there might be an abnormality in the corpus callosum.
But not
Definitive diagnosis of absence of corpus callosum agenesis, I would still wait till 18 weeks at least.
So any invasive done for any reason, you still need to do a structural scan at 18 to 19 weeks to see, and maybe keep the DNA saved if you've done just a karyotype. So it was confirmed on a fetal MRI also. So the same question we've already discussed. Do we do microarray for all the cases of dual marker positive is what needs to be looked at. So now the prognosis, maybe Ashita, you can take from here. Should we do a re-amnio now? And now what to do 30 weeks ACC? Can we help her somehow?
Yes, ma'am. We should counsel our patients that in complete agenesis of corpus callosum, approximately 70% of the fetus have normal neurodevelopmental outcome. Apart from it, 15% of the baby may develop or may show other abnormalities at birth. Let parents decide what they want. If they want to continue pregnancy, it is their wish. And amniocentesis can be suggested at this point of time because it may be associated with various microdeletion, duplication, and syndromes and single gene disorders.
So my patient is asking, even if I test it now, what can I do? You are saying 30% will have mental retardation. No, you said 70% are normal, but
normal neurodevelopmental outcome.
30% is a big number. So,
ma'am, so we should counsel that if there is an additional intracranial or extracranial abnormality, it decreases or it prognostication is bad in that condition. If it is isolated agenesis of corpus callosum, then chances may be fair.
So this is not isolated. It has got interhemispheric cyst, complete corpus callosal agenesis, plus the cerebellum.
The prognosis is bad here, ma'am.
So is there any option we have for them?
Yes, ma'am. We can go to court for the late termination of pregnancy.
So this was a time when the medical board had not started and we had to go to court for these termination. So she had to go for medical termination through the court. And while she was moving around in the court and everywhere, she got COVID. This is COVID time. And then she got a permission at 34 weeks for an MTP. So now she's come to us at 34 weeks of gestation. How do we deliver her? I am worried that the baby will come out alive. So, what do we do? We had this newspaper article, baby was born alive after termination and was told, the hospital was told to keep the baby in the hospital till the baby grows.
So this is an ethical issue rather than a medical. If it would have been, if I would have been the treating doctor, it would have been very difficult for me to name it as MTP and deliver a baby of 34 weeks. But still, if the court has given the diction that MTP has to be then the 34 weeks, then after taking proper consent from the parents, after telling them that the baby will be viable, it will be around 2.4 kg to more than that, and the baby might be alive several days after birth, and sometimes even without resuscitation, such babies recover without any NICU or any setup. So they'll have to look into what could if the baby spontaneously expires within a few days, it's fine. But if the baby remains there, what is to be done? That has to be discussed with the parents as well as the family, and can be addressed by the medical board as well.
So this was the first case that we had when we had to do a 34 weeks. After that, we've done around 40-50 of such cases. So now we are offering them KCL reduction, and then allowing them for termination of pregnancy. So all these cases have to be discussed with the parents. The medical board may or may not give the permission for feticide, but it is part of the method of MTP that you will do. And so at the time of the KCL reduction, we did a cord blood sampling as well, because we wanted to be sure of what genetic test she has. So Sakshi, I have this report of this patient. We first sent for a clinical exam thinking that probably agenesis of corpus callosum will be picked up on this. And it showed a microdeletion of 17q pathogenic. Does exome pick up deletions? And the second report is of a microarray of the same patient, because the geneticist wanted to see what deletion there is. So maybe you, being a clinical geneticist, can help us. Which test should be sent for this case?
Ma'am, actually nowadays the pipeline has been changed for whole exome sequencing. In the pipelines, along with the point mutations, there are certain methodologies and pipelines which are used, which can detect copy number variations to some extent. But yes, this is not a diagnostic test for copy number variation, and there is most of the labs, they give this report with a disclaimer that these microdeletions should be confirmed by an alternative method, by test like chromosomal microarray or MLPA if it is available.
So here this patient has got a 17q microdeletion, which is pathogenic. So what will be the recurrence risk, Ashita? And what will we do for her next pregnancy?
Ma'am, recurrence risk depends upon the which syndrome. It is heterozygous autosomal dominant condition. So it may be de novo or maybe if it is an autosomal dominant, ma'am, in this condition, I will take the help of my geneticist friend, because if it is a de novo mutation, then chances of having recurrence is very low.
So best thing is, when you are in difficulty, get
Yes.
the help of your geneticist. So
Yes,
this
ma'am.
is a deletion that we've seen, 17q deletion. So Sakshi, what do we do?
Ma'am, generally these are de novo, but parents testing can be done to look for whether it is inherited, and that will determine the risk of recurrence in the next pregnancy. If one of the parent is a carrier or has some translocation, the recurrence risk will be 50%. Otherwise, mostly they are de novo, and recurrence risk will be very less than 1%.
Most of the time these are de novo because the parents are normal, but it would still be a penetrance which is less. So here parents were tested and microarray was normal. So her next pregnancy was followed up routinely with a routine FTS. No, do you want to do a testing in the next pregnancy, Megha?
Yes, ma'am. Yes, ma'am. Definitely. I'll offer invasive testing for the baby, for the patient.
The parents
And of course, the scans have to be done regularly, but I'll definitely offer a CVS for her at 11 to 12 weeks.
Sakshi?
Ma'am, actually the recurrence risk is very less. It's less than 1%. So maybe we can leave it or to the discretion of the parents if they are willing. But generally, it's not a strong recommendation.
Ma'am, I would say that once a baby is abnormal and they have gone through a trauma of delivering a 34 weeks baby, a fully viable baby, the parents themselves will come to us saying that we don't want an abnormal baby again and we want 100% testing. So we should definitely offer, and if they refuse, it's fine. Do a normal scan, do the scanning and all, and then.
And then have to tell them nothing can be 100%. We are looking at micro deletions. We are not looking at genes and anything else. So that should be counseled.
So definitely what we learned from this is, one, that maybe you should have kept a DNA saved after a fission karyotype for any kind of testing that you do. Second is, yes, anomaly scan is very important. They would not have gone through all this had they come at 18, 20 weeks. And maybe then we could have terminated at an earlier stage. And the recurrence risk here is going to be very, very less. So you could still offer a CVS for microarray now. Or you could just tell that we'll do the scans and do well and see. So here they went on with a routine screening and had a normal baby. So the recommendation from ACOG and fetal medicine guidelines are, whenever there's a structural abnormality, you should do a microarray. But if it is for something which is structurally normal fetus, either microarray or a karyotype is recommended. So maybe we need to look at what do we do in our Indian situation. But I would think DNA is what we should always say for all the cases where we are only doing a karyotype and the fish is normal, as what Megha said. So let's go on to our next case. And for this, we have Dr. Jaya back with us with Simona, and maybe genetic things Sakshi can add on to. So we have this primigravida low risk DCDA twins, 17 weeks, and she came for anomaly scan a little early and it was completely normal. And then she came a little later at around 22 weeks, and we are seeing this small ecogenic area in the heart. So, Dr. Jaya, is this intracardiac ecogenic focus or is it something else?
Ma'am, this
You
looks
missed it.
like a little too big for an echogenic intracardiac focus, and this looks like a tumor in the heart, most likely a rhabdomyoma.
Yeah.
Those are the most common tumors in the cardiac system.
So did we miss it at 17 weeks?
Not really. This is one of the family of tumors which have a notoriety of appearing a little later in gestation. And therefore, the first thing we would do is tell the patient that this is nothing that somebody has missed on a prior scan.
So now we have DCDA twins and one baby is having rhabdomyoma. Will you do an amniocentesis for one baby or both of them? The
Ma'am,
second baby
twins.
can.
Yes, ma'am. The second baby is a sibling of a potentially abnormal baby, so has to be tested as a dictum always.
And especially because it is something to do with tuberous sclerosis, the other baby can develop rhabdomyoma later.
And 50 to 80% association with tuberous sclerosis is a too high a figure to actually not be considered for testing.
So Sumona, patient says, I don't want an amnio for both. The one which is bad only we will test, the other we will not test. So if the patient says that, will you agree to that? Sumona?
Dr. Sumona, you need to unmute.
Yes, ma'am, sorry. So we would explain the patients that this is an autosomal dominant condition, and if the parent is having this, so there are 50% chance that both the babies would be having this. One may have developed a rhabdomyoma now, and another one may develop it later. So we would counsel her. We would give her the option. Then obviously, if she wants to go for the amnio of a single baby, then we can't help it. It is the consent of the parents which we must respect.
So rhabdomyoma is for reduction, or we can just let them continue, and how do the babies fare? Dr. Jaya can.
So we have to explain the patient what are the challenges with which these babies are going to experience later on in life, and accordingly, if they want, we can reduce the baby, and if we can terminate, or if they want, because later on with treatment these babies tend to do better after birth, so they can continue, but at the same time it is all according to the parents wish, because they have to look after the babies and they have to carry on with it.
We
I
will
think
also
the
look
trait
at the
of
brain also for tubers.
yes, for kidneys also have to be looked at. The brain has to be looked at. The lungs have to be looked at. And
but then
also,
the
I
brain
think
tumors has to be looked at, or can be looked only later on in the pregnancy. The
sweetheart, the chance of spontaneous resolution is excellent in a majority of cases, and therefore I think the approach in today's times is more pro fetus, as all of us would agree, and we would give every fetus a genuine chance at survival before we predict an ominous outcome. So I would personally suggest the parents that there is a really good chance of resolution and there are potentially great therapies ahead, looking at the literature available, and therefore something positive can definitely come.
So we tested the one which had the rhabdomyoma, but then because the risk of 2 procedures, and then anyway she was 23 weeks, and we had not offered her termination for the reason of rhabdomyoma. So it came out as TSC2, autosomal dominant. So Sakshi, I know the diagnosis, so can I just send for TSC2 only, or should I send for a whole exome in this case? Here I am very sure it is going to be only tuberous sclerosis we are looking at.
Yes, ma'am. So mostly in case of rhabdomyoma, as you already told that mostly it is associated with tuberous sclerosis. So we can do a panel testing also for focusing only on tuberous sclerosis in these cases. So these are very few indications where we are very sure of diagnosis and we can use these kinds of panel testings.
So we said, okay, let us continue. It's a small rhabdomyoma. And by 31 weeks, it had become huge. There are multiple of them. So even all around the myometrium. So still you can continue. You don't need to deliver them early because they do not have any other problems and the cardiac function is all right. So we can take them till term.
And these tumors tend to decrease. The size tend to decrease later on, where after the babies are born. So it is not that this is the size which is going to remain.
So Dr. Jaya, when will you want to deliver them? DCD8
Ma'am,
and with
so-
rhabdomyoma?
Ma'am, the first thing that you have to follow these pregnancies up, because as you said, the tumors are growing in size. So there can be presentations which will change our plan of action. If everything goes fine, then we have to take it to term, as you said, maybe 37 with 38 weeks, I'm going to take it up to that point. However, there is a possibility of a mediastinal shift. There's a possibility of a hydrops developing. There is a possibility of an arrhythmia developing. And therefore, a constant watch has to be kept on all of these events. And once they develop, then of course, our prognosis and our plan for termination would be merited by those conditions.
So we delivered her at around 37 weeks of gestation, DCDA twins, and we tested the parents and the sibling, and all of them were asymptomatic, did not have the TSC gene. So it was a de novo autosomal dominant in one of the child, and the second child and the parents are normal. So this is the child who is growing up. They keep sending me photographs and saying that, yes, this baby is also doing as well as the other one is. So we go on to our next case, and for this is a very non-specific abnormality that we saw what test to do. So for this, Dr. Sangeeta, Ashita, and maybe Sakshi can add on if required. So primary gravida, orthopedician's wife, came with this pleural effusion, nothing else. No edema, no ascites, no scalp edema, screening done, only this pleural effusion, bilateral, one side more than the other. So how will you counsel Dr. Sangeeta, and what test do you want to do? Do you want to do a shunt in them?
So, first of all, I would like to do a detailed anomaly scan and I would like to rule any structural abnormality if it is there. If it is isolated pleural effusion, then I would like to do invasive testing and I would like to do the karyotype because it can be associated with the chromosomal abnormalities. And we have seen trisomy 21 presenting with isolated pleural effusion only. So that I would like to rule out. And once we have ruled out any chromosomal abnormality, then definitely I would like to follow this. If it is mild, then we can keep on following this. Sometimes these are, if there is no underlying cause, they can gradually resolve on its own. Because once the lymphatic channels develop, they might resolve as the pregnancy progresses. But if it is increasing, then definitely we need to see, and we can always plan fetal therapy in the form of pleuroamniotic shunt.
So Ashita, madam said that we can do a invasive test in this. So will you be satisfied with only a karyotype, or you want to do more tests because she's a doctor's wife and they want all the tests to be done, want to be sure of what the disorder is?
Ma'am, actually, it is maybe idiopathic reason, maybe associated with Down syndrome, and actually the most common cause for first trimester pleural effusion, apart from idiopathic reason, is Turner syndrome. So once we have ruled out, we can go for array testing. Along with, I will like to go with torch test of the mother also to rule out any infection. And I will like to store DNA to rule out because it may be associated with Noonan syndromes also. So it is better to store DNA at this point and torch testing in mother along with array.
So we are not terminating this pregnancy, no? So keeping the sample saved is not going to help us much They want answers for everything. So can I do everything? Fish, torch PCR, microarray, whole exome, Noonan panel, because they want answers. Otherwise, she's 21 weeks. She wants a think of termination if required or putting in a shunt. So do I do all these tests all together? Dr. Ratna in the morning said that we don't do exome testing just for the non-specific abnormalities.
Ma'am, actually, according to Fetal Medicine Foundation, what they say that if increased anti or it is present, if we are suspecting Noonans, then we have to
There's no
rule
increased
out it
anti.
in
This is
second
a 21 weeker fetus.
fetus. So, ma'am,
21
we
weekers.
can go for fish test along with microarray and Noonan panel.
So, Sakshi, any additional things you can?
Mostly these late onset pleural effusions, they have comparatively stronger association with Noonans as compared to those early onsets. So definitely, if the parent is, if with this finding and parents are very much interested in doing the whole testing, we should always offer exome sequencing to rule out Noonans syndrome.
So we did a fish plus a torch PCR as what Ashita said, and we added a whole exome to our panel and a microarray also. And at the same time, we did a pleural tapping to see what comes up in the pleural fluid. So pleural fluid was serous, the fish was normal, the torch was normal, the microarray was normal. And by the time these reports came, she was 23 plus 6 days, and the pleural effusion had filled up again after the shunt. And the report also came, and it came out as Noonan syndrome. So these non-specific tests, there is a lot of difficulty in deciding what test to do. And here, because in a second trimester pleural effusion, and you want the patient to continue pregnancy, you actually need to do these tests to find out what the disorder is. And here, because it was Noonan, autosomal dominant, and the parents were at 23 plus 6 weeks, they decided to terminate pregnancy on the grounds of Noonan. No other abnormality. We go on to our next case, and for this, I have Megha Preeti with me. Megha. So we have this patient who's 27-year-old, gravida 4, third degree consanguineous marriage, 3 previous neonatal deaths. 2 of them had a documented CNS malformation. So the first one was delivered in a village and died on 3rd day of life, nothing done. Second pregnancy, she had scan done with us late in pregnancy, cerebellar hypoplasia. Amnio was done and terminated pregnancy. And we kept the DNA saved, we will work on it later on. But because COVID came in, she did not come back to us for the DNA analysis. And third pregnancy again came at 29 weeks in pandemic with again a pontocerebellar hypoplasia. So these are those pictures of the third baby where the cerebellum was small, nasal bone is seen, there is microcephaly, there is an interhemispheric cyst that we see, and there's a clubfoot. So now she is at around 29-30 weeks. So what can we do? What test to do? Do it now, or exactly what do you want to do for her?
Ma'am, I think because she has had recurrent similar type of malformations, it is definitely going to be the first line would be a single gene disorder. And since she is a consanguineous married couple as well, so we'll definitely, even at 29 weeks, although we know definitively that the baby has malformations, we'll offer an invasive testing for the same grounds that after birth, if we take the sample of the baby, it might not yield a good sample. So we might offer an invasive testing for her. Although on the same grounds, she may be offered MTP also after a proper opinion of the committee and the code and opinion from the court, because she has already had similar babies with who died early in the neonatal life.
So Preeti, this patient had a karyotype which was normal, and as what Megha said, we need to do a single gene testing for this patient. So can I do it postnatally anyway? The patient wants to continue and want to see later on. So will it be better to do it postnatally or antenatally amniocentesis? Because she wants to continue pregnancy.
Anyway, madam, she had first baby's DNA stored, the previous baby, second one, where there was this karyotyping was done and it came to be normal, but further testing was not done in that baby. So in this baby also the same finding, there is same repetition of pontocerebellar hypoplasia. And because they are third degree consanguineous marriages, so we can suspect autosomal recessive condition which has come. So definitely the previous one DNA and this baby, both this dual sample has to be tested. Amnio has to be done and has to be tested.
So because this patient was in a general hospital and and she wanted to deliver with us and then send the baby for testing. So we were prepared more because the phenotype was more evident now and we could see what all was there. And so we decided that you deliver with us and we send the test when the baby is born. And so this was delivered, and microcephaly, CTV and cerebellar hypoplasia, the baby died after some time, but we were able to send the test of the baby and it had this coesi gene, pontocerebellar hypoplasia, homozygous, autosomal recessive, and both the parents had the same carrier. So we could test the baby. When you have recurrent abnormalities, it is best that the baby needs to be tested and then the parents testing was done. And so the recurrence is going to be
25%. 25%.
25%, as it is an
25%.
autosomal recessive condition.
So in the next pregnancy, what will you do?
We'll do a prenatal.
Chorionic villus sampling for single gene.
Sanger. We'll do a Sanger sequence.
Variant test.
Sanger
So
sequencing
now
for
you
single
will
gene.
just do one gene, whichever we know is the coesi gene. So you will send for a Sanger mutation, and this was found to be only heterozygous carrier. And so they finally had one normal baby after 3 abnormal babies. So the learning is that if you have recurrent abnormalities, then it may be worth doing a exome sequencing in those cases. So I took it from the ACMG that prenatal exome sequencing may be reasonable in select circumstances, either in the fetus with multiple anomalies or in cases with recurrent fetal phenotype with no diagnosis by karyotype or microarray. So whole exome may help in these some cases. So I think if I have some 10 minutes, we'll do 2 more cases. So this is a very beautiful air hostess who came with her first baby having binders somewhere else, not evaluated. These are images of some other place. And because it was looking so bad, they just terminated this pregnancy and did not do anything for this. So for this, I have now Dr. Jaya, Sakshi, and maybe Sumona also. What test do you want to do in this baby? Or
Ma'am, first I have to look at the entire baby when I see a binder's phenotype, because this is a conglomerate of too many diverse heterogeneous conditions. And the first thing I will do here is look at the parents. Because that gives a clue to where exactly is this baby going. And that's a very free
she's
kind
an
of a
air
thing.
hostess. She's an air hostess, beautiful husband.
And next, ma'am, I have to take a look at the entire baby. Because I have to look at the bones. I want to see if there is stippling sitting over there. I have to look at the calcaneum. I have to look at my humerus and my femur to see whether I'm looking at a straightforward case of chondrodysplasia punctata. Then I have to take a close look at the mother to see if I'm seeing a malar rash and this is SLE that I am looking at. So if she hasn't applied a blusher and she's still blushing, I have a straightforward diagnosis at my hand. Besides this, I have to also look at the cardiac condition of the mother. Maybe she's on warfarin, that is what is giving rise to this kind of a phenotype. So I think maternal fetal medicine gives me a balanced idea of what I'm looking at in these cases, and the mother is equally important here. And once I have ruled out those kind of disorders, then yes, chondrodysplasia punctata in itself again is not a diagnosis. So we have to delve deeper and do invasive testing here to see where is this going.
So this was
also look at rhizomelia also. No, I mean, rhizomelia can again give me an idea of how bad the condition is going to be. And also, if my phalanges are giving me a distinct idea and rhizomelia is not a part of the spectrum, then maybe I might be looking at something like a vitamin K embryopathy or something. So that differential also has to be one.
So in this first
Also
phase,
associated with aneuploidies. sometimes binders phenotype is also associated with aneuploid. It's not to forget that also.
So this is the second baby again with the same binders. First one wasn't evaluated. The second one is like that. And now she says, I want to test everything that we have. So do we do again after birth or we do it antenatally? She wants to terminate binders. No other option. Prenatally. But she wants to terminate because she doesn't want, there was no chondrodysplasia punctata, there was no other disorder, she didn't have any other autoimmune SLE, and everything came as normal. And as it happens that if we do an exome in such cases, they will always come out as these uncertain significance, where we don't know what is the cause for this. So now we have this nonsense report of this uncertain significance. She has had 2 babies with the same binders. So what do we offer her for the next pregnancy, and what is the empirical risk we are going to give? Sakshi, can you speak on that?
In this case, as we don't know the cause, because this variant of unknown significance at present with the present scenario, we cannot, these may or may not be causative at present. So for the next pregnancy, yes, recurrence may be there, but these I have seen 2-3 children with these flat facial profile who are absolutely normal. But during their prenatal, there may be some flat facial profile. After birth, there could be, but that eventually improves as the child grows. So that could be some normal variation also, which we need to tell to the patients about this.
So we can just counsel them that this can be all corrected if there is no other genetic disorder, and let her not have another termination only for the structural abnormality of the flat faces. So in this second patient, we actually did an autopsy to see, are we missing out on anything? And there wasn't anything else except the flat faces. So the next pregnancy, she came back and the face is all we kept looking at, and the face was looking normal. And so every time she would say, show me face, and then I will continue. And she went on with a good baby. So these variants of uncertain significance don't need to be tested. So in this pregnancy, because there was nothing else, we have not tested anything. And she went on with a good fetus. So last of all, Sita, do I have 5-10 minutes?
Yes, you can have the one more case. Very interesting. Carry on.
So we have, so now we have for this Dr. Sangeeta and Preeti with me. 28 years. She's a gynecologist herself. First baby neonatal death on day 1 of life. Vaginal delivery 2.9. Second baby good section, everything well. She had a good screening, anomaly done, but at 29 weeks, all bones were short. She's a gynec herself. Her mother is also a gynec. And these are the bones shape at 29 weeks, and that's the head we have. So, Dr. Sangeeta, what do you comment on these scan reports?
So now we need to understand that there are certain genetic conditions in which there are like achondroplasia, which will not present in first and second trimester, and it might present first time in the third trimester itself. And then she has this history of previous neonatal death also. So there might be some underlying genetic condition. We need to explain that. And then we can offer invasive testing. And then we can go ahead with the, we can directly offer exome in this case, because skeletal dysplasias will not get picked up on karyotype and CMA. So that is what we can do at this gestation.
So, Preeti, any comment on the shape of these bones? They are short, but are they not looking very thick and anemic?
Thickened, yes, madam. Whether the first baby, anything was done, that neonatal death?
That was, no, nothing was given.
Nothing was done.
It looked normal.
Okay, so in this case, as she told, we can go for rapid exome sequencing, and we can explain them that all the short, long bones, we can only know by 28 weeks because they are late onset anomalies. So we will go for rapid exome sequencing. So we will get the report earlier.
The thorax was short. There was, we look at the head was normal size and the femur was so small. So we spoke to her and she said, I will take it till term and let us see what happens to it. So we will test at birth and maybe that time we'll decide. So she did a cesarean section with her mother only at 37 weeks of gestation, as she was a previous cesarean section, and continued, and this is what the baby was. So maybe Sakshi can help us describe what it looks like. There was gum hypertrophy.
It looks like on the faces, if you see, there are many coarse features which are there with, depressed nasal bridge, these thick lips, gum hypertrophy. So basically, we describe these as coarse facial features with short limbs.
So is it a skeletal dysplasia or it can be something else also?
These coarse facial features gives me some suspicion of storage, some kind of storage disorder with this gum hypertrophy, depressed nasal bridge, flat facial profile. So most probably some storage disorders like mucopolysaccharidosis, MPS.
So we started off thinking it to be skeletal, and now you are saying after birth that it more looks like a storage disorder.
Or depending on the facial phenotype, ma'am.
Yes. So this was the infantogram which was done, which was also showing those thick bones. And as you said, right, this was genetically tested and it came out as mucolipidosis type 2-3. And this was autosomal recessive with the inheritance of this patient was homozygous. So the recurrence is going to be 25% in all those patients. So here what we started off thinking to be skeletal came out as a metabolic disorder. And so sometimes amniocentesis may help, but sometimes it is postnatal evaluation which gives us more information on the phenotype of the baby.
Also, ma'am, if I can add it here, ma'am, that there's a certain, like for all skeletal dysplasias being a very wide array of disorders, it is the criteria for lethality that might help us determine the prognosis. And here a narrow thorax, cardiomegaly, there were things that were pointing towards a bad outcome later. So maybe those could have also been taken into consideration besides, of course, the genetic
And we
test.
can't make a diagnosis of skeletal dysplasia on an ultrasound itself.
Absolutely.
To just tell whether it's lethal skeletal or it is a non-lethal skeletal dysplasia, and maybe some pointers to one from the other. But finally, we will need to do, earlier we used to do skeletal panel. Now we do a whole exome to find out whether whatever the genetic disorder. Some 10 years back, there was a skeletal panel for these that we used to send for. So our last case, 25 years old, registered at 8-9 weeks, first pregnancy preterm, 26 weeks. She came with polyhydramnios in the emergency, delivered, and baby died. So next pregnancy now, she has come at 30 weeks, again with severe polyhydramnios, started on indomethacin, A5 was 32, baby weight was 900 grams. Again came in the emergency and she delivered. So what can be the diagnosis? Severe polyhydramnios 2 times with a big bladder. So Sakshi, how do we work on these? Do we send for any test? She doesn't have any structural abnormality, only poly and preterm.
Ma'am, see, in recurrent case, first pointer is recurrence. Second is this huge polyhydramnios which is there. So one diagnosis which comes to my in mind, taking in. So for every polyhydramnios, we don't do such kind of aggressive management. This has to be considered. If it's mild polyhydramnios 26, 27, then we have to rule out common associations like maternal GDM. We have to do structural evaluation. But in case of this recurrence with such a severe polyhydramnios, definitely only one diagnosis which comes to my mind is Bartter syndrome.
So now I am suspecting Bartter syndrome. What test do I send for? We've looked at sugars, we've looked at everything. Severe poly at the moment, she's not still delivered.
More of these neuromuscular things have to be ruled out first with these. So when everything is normal, for idiopathic cases with severe polyhydramnios, then we think of Bartter's.
So Megha and Ashita, what will you do? She's still not delivered. She's there with that severe stomach in front of her and poly. Do I send for a test? Do I wait for the test and do it postnatally? And what test to send for?
I'm recurrent. I think I'll offer a testing for her, because since she is structurally absolutely normal, and we can do a testing, and we can of course counsel the patient and do, if she wants. We know the prognosis of what the prognosis of the previous babies had been. We can do a recurrent amnio drainage, repeated amnio drainage for her along with indomethacin, and we can prolong the pregnancy as far as possible, so that at least the baby is salvageable, and then we could evaluate the phenotype of the baby. Until then, whatever the amniotic fluid that we get, we can send it for a whole exome sequencing, keeping in mind the Bartter syndrome, and mentioning the clinical features and the suspicion to the labs as well, and
We are
ask
not
for an
talking
early
about
reporting.
microarray at all. We are not
Ma'am,
of
since
microarray.
no structural abnormalities are there, and there is a recurrence of the same, again, we are having the same phenotype in three subsequent babies. So I'll be first concerned about single gene disorders for it. And I may ask the lab to go for CNVs, a whole exome sequencing with a CNV evaluation, so that we might not miss the usual deletions and duplications.
So Sakshi, is there a combination of microarray and exome some labs are giving? So how does that work?
Ma'am, that's what I had discussed, that they are doing NGS based copy number analysis, but definitely with the disclaimer that if any microdeletion is detected, that has to be confirmed by a alternative method. So whenever we are suspecting, that depends on our suspicion. If we are thinking more in terms of chromosomal abnormality, then we'll do CMA. But yes, when we are suspecting more of a single gene, then single gene with copy number analysis you can add on.
So Dr. Jaya, what will you do in your place? Polyhydramnios. You will get lots of these polyhydramnios. Do you always think of Bartter?
No, ma'am. I was about to add that recently we had a case. She had lost her previous two babies, unexplained deaths with polyhydramnios. And the only cardinal feature we could see on repeated scanning was that the baby would be at the bottom of a sea of water. This baby was not swimming into that sea of water and was constantly at the bottom. And the bladder, as you say, was big here, was not visualized well. And that is how we came to the diagnosis of a fetal echinacea deformation sequence, and we investigated further thereafter. So yes, there is a possibility, and we have to do, I mean, a microarray is where my needle would swing actually first. And of course, with DNA storage.
Fetal akinesia also mostly these are maybe neuromuscular and mostly maybe single gene.
Yes, both. Yes, both actually.
So it could be both. So this patient had an AFI of 50 and 33 weeks. In spite of indomethacin, she delivered 1.8 kg preterm delivery. And yes, it had electrolyte imbalance. It had the Bartter syndrome that we were thinking about. And the recurrence for all her pregnancies is going to be her parents, we will check, and because it was homozygous and Bartter syndrome, the recurrence is going to be high. So she will require a testing at CVS time at 12 weeks of gestation, so that she doesn't go on with such babies every time preterm and deliver them. So yes, that is probably the end. I never expected that we'll finish all our cases. So hats off to all the panelists to work with me and get all these cases solved. And Dr. Sita for giving us this opportunity for taking us our cases through.
Dr. Bansal, this is my third or fourth panel with you, and I must say that now I've started looking forward to your panels. I really, really thoroughly enjoy them. And Ma'am Sita, thank you so much for bringing us all together. Thank you really so much.
Thank you, ma'am.
Thank you so much, ma'am.
Thank you,
Ma'am,
ma'am.
we can have even
Thank
more
you, ma'am.
cases.
Thank you, Sita ma'am, for this opportunity.
So it's a wonderful collection of cases Madam Bansal
Yeah.
has, and every time we learn something new. So thank you so much for that. And though it's almost, we are an hour and a half late, but it has been interesting right from the start with
Yes.
a lot of experts and a lot of learning. So that I, propose my official vote of thanks. So big thanks to all our leadership, the FOXY leadership, Dr. Jaideep Tang, President, Dr. Madhuri Patel, Secretary General, the ICOG Chairperson, Dr. Parul Kodawala, Secretary, Dr. Sarita, Vice Chairperson, Dr. Sheila Mane, Of course, our guest of honor, Dr. Jaideep Malhotra, and our special guest, Dr. Soonawala, who stayed right till almost half the program, which I must commend him. And of course, the speakers, Dr. Seema Thakur, Dr. Shagun Agrawal, Dr. Veronica, Dr. Ratnapuri, Madam Chinmay, and Dr. Kailash Nathade from the UK, with all the chairpersons pitching in, Dr. Rakhi Singh, Dr. Mala Arora, Madam Dr. Kushagrati Ghosh, Dr. Geeta Balsakar, and of course, an excellent panel, Dr. Vandana Bansal. Thank you so much for that, with all the expert panelists with crisp and very informative inputs about how to go about each case. Dr. Jaya, Dr. Sangeeta, Dr. Sakshi, Dr. Ashita, Dr. Sumana, Dr. Preeti, Dr. Megha, and a big, big thanks to our MOC, Dr. Shruti Jain, for beautifully conducting this seamlessly. And of course, the ICOG team for giving us this platform. I must say we had a lot of requests coming in to join. They couldn't join. So we had put a YouTube channel, and I'm going to share the recording as well. So for whoever who have missed or could leave halfway, we're going to give this. So thank you so much once again. Have a good day and thank you.
Thank you.
And a round of applause for Ma'am Sita.
Yes. Thank you so much. Okay, good night.
Ma'am, good
Thank you. Thank you, everyone. We thoroughly enjoyed.